Okay, well, let's get moving. So, geriatrics. When we're talking about geriatrics, we're talking about our older folks, which if we think about the demographics we have since covered through this course, the old, the sick, the morbidly obese, we're about to check off the old. Let's talk about them. Now, realistically, this is going to be, honestly, probably your most frequently seen demographic. You know, and just because they're older doesn't necessarily mean that, you know, it's a normal part of getting old is getting sick, but the older we get, there are, let's say there's more opportunity for injury and illness just because of the body's natural breakdown, okay? So geriatrics is the assessment and treatment of a person 65 years or older. So anyone with parents older than 65, tell them they've hit that geriatric mark, they'll love it. But geriatric patients present a special challenge, especially for healthcare providers if we consider multiple health conditions, right? These are people that have lived a bit of life. So they may have a few things stacked up that might make our care a little more difficult. And then injuries and illnesses are affected by chronic conditions, multiple meds, and the physiology of aging. There's a few different factors we've got to keep in mind. Now, some considerations, generational considerations. It's important to understand and appreciate how the life of an older person might differ from yours. These were some of my favorite patients, and the reason they were is because a lot of them have a lot of cool life experiences and stories that you're just not going to hear, right? That's not a normal thing for us to talk to. You know, maybe for your family it might be, but like for me, having good conversations with like Vietnam veterans who have telling me crazy stories about the things they saw and did over there, right? It kind of gives you, as just an example, gives you an appreciation for these folks. So don't just do the thing that I've seen a lot of providers do where they get really like, oh, it's just another old person who fell down. It's part of the job. You signed up for this, right? At least make the most of these interactions. Now, it takes time and patience to interact with an older person. Remember, treat them with respect. You know, I'm sure a lot of you have heard the respect your elders, and I think there is a grain of truth to that. At the same time, I respect the people that give me the same respect. So just because they're old doesn't mean you have to respect them, but be respectful for your job perspective, okay? Remember, we're there to provide service and help these people out in times of need. Maybe don't be mean about it, okay? And then make every attempt to avoid ageism. So not every old person has dementia, not every old person's hard of hearing, not every old person's sedentary or immobile, okay? It really just depends. I have seen 103-year-old ladies who are moving better than the 70-year-old patient I just talked to, okay? So just because they're old doesn't necessarily mean they're out of the game by any means, okay? Treat them accordingly. So communication, that's going to be something that you guys will struggle with a little bit depending on, you know, your experience with this demographic, but it can make things tougher, okay? Hearing impairment, visual impairments, there's sometimes going to be even speech impairments if they have past conditions, so things that might make our job tougher, and we're going to have to find ways to work around, and you're going to have to be creative from time to time, okay? So effective verbal communication skills are essential. So when it comes to our conversation with these folks, speak respectfully. Make sure you're identifying yourself. Okay, a lot of times with these older demographics, it's not often them who are calling 911. Okay, it's not an uncommon thing for us to show up to like a nursing home facility and we walk into a room and they're like, "What are you here for?" The nurse called, right? So we got to just kind of introduce ourselves, let them know why we're there, and then we can start that conversation. Be aware of how you present yourself. Talked about this since the beginning, right? There's optics on you always. Kind of pay attention to how this situation might look. And then look directly at the patient at eye level and speak slowly and distinctly, okay? A lot of us especially, I mean, you guys have all noticed by now, is when I get a little excited about something, I start talking really, really fast. And it was the same thing as when I was out there. And it could be problematic when I was talking to older folks. So for yourselves, learn from my mistakes, slow down, really enunciate your words, and give them a chance to understand you. Have one person talk to the patient and ask only one question at a time. Now, when we show up, usually, you know, if it's gonna be an ambulance crew of 2 people and then a fire crew of minimum of 3, okay, so 5 of us in that room, and we're all trying to talk to this same person at the same time. It's a lot of cooks in that kitchen, okay? If you're gonna be teching this call or leading this call, make sure you're the one asking questions. Now, I'm not saying ignore everybody else's questions, but kind of maybe be the mouthpiece for it, okay? Don't assume that all of them are hard of hearing. Give them time to respond. Make sure you're listening to the answer. I know that sounds really silly, but as newer providers, you guys are gonna literally sit down and you're gonna say, hey, my name is so-and-so, and you're gonna forget everything you've ever learned in that moment. It happens to everybody at least once. On that same note, when you're asking these questions and you finally start talking to a patient, it's not uncommon for, as you ask a question and you're waiting for their response, you're thinking of your next 2 to 3 questions, and then you missed what they said, and then you gotta circle back, okay? And then explain what you'll do before you do it. Keep them in the loop with their own care. They've been around long enough to kind of deserve that. So, some common complaints and the leading causes of death in older people. Can someone tell me, before we even get too far, if we think back to our neuro lecture, what one of the most common conditions is for older people? How was it? Dementia, not quite. Not wrong, but not quite. It's the number one killer, or killer of 80%. Strokes, that's what we're looking for. Yeah, ischemic strokes, hemorrhagic strokes as well, but strokes are gonna be a big deal, right? So if we think about leading causes of death, that's something that, frankly, I saw all the time. So just keep that in mind, right? You already have an idea of what could be a common issue, okay? Now it's our job to prove ourselves wrong. Now that stroke's obviously a specific example, but it's another example nonetheless, okay? We can kind of pre-prepare ourselves. So, geriatric population is predisposed to a host of problems not seen in the youth. For example, hip fractures, very common, especially in older, in my experience, older women. They get that osteoporosis moving into the next line, they have weakened bones, okay? Well, older people tend to fall at a higher percentage as well than the rest of our demographics. You know, children and old people kind of run hand in hand there. So they have an increased likelihood of fractures as well. And then on top of it, as people get older, they develop some sort of sedentary behavior. Now, not all of them, but some of them will develop a sedentary behavior. What does that mean, sedentary behavior?
They're not moving around very much.
They don't move around very much. Yeah, they sit in their recliners, all right? I'm sure we all can think of an old person in your life where every time you see them, they're sitting in that one chair, right? That sedentary behavior can lead to things like blood clots, okay? And then if they're sick, that's where pneumonia starts to settle. We need to keep moving. As you keep moving, as they say, motion's lotion, it keeps everything moving the way it should, okay? Helps us get rid of clots, helps us clear clots, it helps us to clear our lungs, right? I'm sure you guys have noticed after you've been sick and you go for like a jog or you even walk harder, you start coughing and getting all that gunk out of you. Well, that's an important process. Otherwise, it settles down and then we got pneumonia, okay? So, list of common conditions and causes of death. I will let you guys go through that. Now, let's work our way through the body. This lecture is going to be a little bit lengthy just because we got to break down each system a little bit independently. Okay, so aging process accompanied by changes in our physiologic function. Okay, so how our body works. So all tissues of the body will undergo aging with some decreases in capacities happening. So various organ systems aren't going to work as well, which is normal. But it can also affect how that patient responds to illness, right? If our immune system doesn't work as well as it once did, illness has a likelihood of progressing, or higher likelihood. When it comes to the respiratory stuff, so age-related changes can predispose an older adult to respiratory illness. Okay, so once again, these are kind of depending on the person's lifestyle and maybe the life they lived prior, but airway muscles become weak, so they don't take as big of breaths, not as strong as breaths. Alveoli in the lung tissue will become enlarged with the elasticity decreasing. That kind of sounds like a disease. What disease does that sound like? Enlarging alveoli.
Asthma?
Not asthma. COPD, but it's part of COPD. Which one? Remember, COPD is the umbrella and there's 2 conditions underneath.
Emphysema?
Emphysema, very good, yeah. Emphysema is think of that barrel-chested, kind of skinnier fella, right? But they have the grapes turning to grapefruit, right? But that's a normal change as well. And that's not to say if they weren't smokers before, right? So there's doubling the damage. The body's chemoreceptors slow with age, so they trap more CO2 more frequently, okay? And then decreased coughing and gag reflexes. They still will throw up, I've seen it. They still will cough, I've seen it. But as far as the reflex goes, it's a little lower. Now, as far as frequency, pneumonia is one we see quite a bit with older people, especially that sedentary lifestyle. So inflammation or infection of the lung, and it can either be bacterial, viral, or fungal. Do you guys remember how to tell the difference potentially between bacterial and viral infections? Temperature. Which one's going to be higher? Bacterial. Yeah. Bacterial is going to be the highest temperature. Think like your 102, 103s. Virals, your 100, 101s. But leading cause of death from infection in Americans older than 65. And then aging causes some immune suppression and increases the risk of contracting infections. If your immune system's suppressed, your likelihood of getting sick goes up. That's why during COVID, that was a big concern, right? The immune deficient people, older folks were on that list, okay? Now, increased mucus production, pulmonary secretions, and infections. So we have a plethora of gunk building up in our lungs, right? Over time are going to make it harder to oxygenate in the alveoli because now the alveoli are full of junk. They're full of gunk, fluid, mucus, right? And the management of pneumonia is going to be the same. We're going to give them oxygen. There's nothing we can do to fix this, okay? I have from time to time seen breathing treatments used on pneumonia patients just to open them up a little bit. Against your protocols, well, excuse me, against the national scope, but check your protocols wherever you land. That might be an option for you. PEs, they start to show up as well, right? Sedentary lifestyle, they're sitting in their chair. If people aren't moving and blood's not therefore being moved with more velocity through the body, what happens to blood as it stops moving? Yeah, it coagulates, starts forming clots. This is where that, like DVTs start to show up, right? The sedentary lifestyle, they get a DVT in their leg. When they finally start moving, they break that clot loose and away it goes, usually landing in the lungs. Now these patients, so sudden blockage of an artery by a venous clot, excuse me, patient will present with shortness of breath, sometimes chest pain, and then can be confused for cardiac, lung, or musculoskeletal, okay? So this is where we gotta kind of use our assessment skills. If we're worried about musculoskeletal, what can we do to maybe rule that out? Palpate. Yeah, we can rule out musculoskeletal with palpation. Well, then from there, it's assessment. Now, you guys at the basic scope can't do cardiac management, right? That's a little bit different, but you can sure listen to lung sounds. You can sure check your SpO2s, right? Remember that pinpoint chest pain as an indicator potentially of PE? Let the location of that kind of guide you, okay? And then once again, what's their SpO2 gonna look like? Anyone remember what the PE? It's gonna be low. What's their lungs sound gonna be like? Clear. So low SpO2, clear lung sounds, pulmonary embolism. Okay, so what are some risk factors? Living in a nursing home. Usually, has anyone ever been in a nursing home before? They're pretty sedentary, right? Most of the people are just kicking it in their rooms, watching TV on a chair, or they're walking around finding a TV in the open. There's TVs everywhere in these things. But that's a big one. They don't move as much. Recent surgeries. History of blood clots or even heart failure, right? If they're with congestive heart failure, they don't have that pumping velocity out of the left ventricle, causes clot buildup. So if they eventually send that out, it can end up heart, brain, anywhere. Presence of pacemaker, central line, obesity, sedentary behavior, long distance travel, and then trauma, cancer, or paralyzed extremities. Why paralyzed extremities? Why does that put us at a higher risk of clotting? Yeah, they're not moving. They're essentially a sedentary limb, right? Or limbs, plural, depending on what it is. Tachycardia usually will kind of go with PEs if we think about, the stress of that situation. You have a sudden, maybe pinpoint chest pain, right? And you're not breathing very good. Stress is gonna rise. That doesn't change as we get older. Sudden onset of difficulty breathing, shoulder, back, or chest pain, cough. Depending on how large the clot is, they can actually pass out. And that's just because they're not oxygenating, right? And if they don't oxygenate their blood, the brain's not getting blood. There we go. Consciousness is no more. And then anxiety will often follow, obviously, right? So apprehension, low-grade fever, hemoptysis. What's hemoptysis again? Nope.
No, that's
Not vomiting blood.
Isn't it like the blood in your eye?
Nope. What is it? Nope. We're talking about lung stuff. Let's put 2 and 2 together. Coughing up blood. Yeah. Coughing up blood is hemoptysis.
What's the, like, ruptured blood.
Scleral hemorrhaging. If you pop a blood vessel in your eye, is that what you're talking about?
Yeah.
Yes, scleral.
I remember reading something. Never mind. Okay.
I mean, look, there's all sorts of fancy words out there, though. So if you can find it, I'm willing to listen. Leg pain, redness with unilateral pedal edema. What does that sound like? Single leg, huh?
CHF maybe?
Well, maybe CHF, but if it's one leg, unilateral, that's probably not CHF. What leads to PEs? The other three letter. DVT, yeah, deep vein thrombosis. Remember that picture I showed you, the leg with the red line where there's that point of clot? And then fatigue, and then worst case scenario, cardiac arrest because we're not oxygenating and there goes the rest of the body. Questions on the respiratory system at all? Okay. Cardiovascular. So the heart hypertrophies with age. Hypertrophy means it grows, it gets larger, okay? That's why, so if you ever go to the gym and you notice there's a hypertrophy workout, it's for building muscle, for getting larger, right? So same thing with our heart as we get older, which if you think about, it's a muscle, it's been working for a long time, right? So kind of gets stronger. Now with that hypertrophy, downside of it is that the heart almost becomes flabby, has the potential to become flabby because it gets so big, okay? So it doesn't have that same contraction strength. Well, if it doesn't have the same contraction strength, the cardiac output goes down. And then on top of that, we have like things like arteriosclerosis, so the closing up of our arteries, putting us at risk, one, of hypertension, but hypertension is the precursor for a lot of things, right? Strokes, MI being the two big examples. Now, geriatric patients are at risk for atherosclerosis, cholesterol buildup in the arteries, closing them off. So, which we think about it, what happens to our blood pressure when it vasoconstricts, when we have vasoconstriction? It goes up. So when we have atherosclerosis, where it's basically physiologically closing that lumen of the vasculature, making the pressures go up. That's a common reason that older folks have high blood pressure, which puts us at risk, once again, of MIs and strokes. So here's a picture. Top one's normal. Bottom one is atherosclerotic, right? So you can see that nice wide lumen is now being kind of impeded upon because of the buildup of that cholesterol. And in particular, it's typically HDL cholesterol. Okay, excuse me, LDL, not HDL, LDL, low density lipids. Now, older people are at an increased risk of aneurysm. This is where we have that high blood pressure over time just pounding on that aorta, pounding on those vessels, that eventually they start to get weak and they balloon out. Okay, so abnormal blood-filled dilation of a blood vessel wall with severe bleeding potentially occurring depending on where it's at, but also just typically there's no great place to have an aneurysm. Okay, so blood vessels and heart valves can also become stiff and degenerate. Okay, this is called stenosis, S-T-E-N-O-S-I-S, stenosis. Stenosis is basically when valves get stiff. Okay, this is also a common reason, for example, dogs, that they can have heart murmurs because the valves are too stiff, so they're not fully closing. So instead of going like this and closing every time, it's kind of going like this. And so it's never fully closing, so you have that regurg or the back spread of blood. Okay, and then the heart rates can drastically change as we get older. The electrical communication system in our heart through those pathways, SA, AV, bundle of His, Purkinje, those pathways can start changing as we get older. So it's not uncommon for atrial fibrillation, very, very common older person rhythm. Yeah, Bryn.
Purkinje's, just going back, is a little something to come back onto the heart.
So it's so SA node, right? If we start up here, SA to the AV, from then that's the atria.
That's where the delay is.
The AV, yep. And then through the bundle of His, and then the Purkinjes are the ones that spread to the ventricles. They're the little fingers that wrap around.
They come back up to the top of the heart.
Yep.
What are they?
They're, truthfully, as far as like, I almost imagine them being like nerves.
Yeah,
like,
are they nerves?
I'm not entirely sure.
Yeah.
I'll double check
Okay.
that. But it would make sense to me too that would be like, that's where that specialized cardiac tissue comes in, and there's more, maybe, don't quote me on this, but maybe more concentrations of it in those areas. But I'll double check, because that's something worth noting. Okay, other vessel-related problems. Venous stasis. So remember, stasis means not moving. So if blood's not moving, it starts to clot. So loss of proper function in the veins and the legs that carry blood back to the heart. I don't know why I said it like that, but DVTs, right? That's what we're talking about there. Potential blood clots. So DVTs lead to pulmonary embolisms. And then these people will usually exhibit edema of the legs and ankles, just depending on if it's both legs, one leg. Usually both legs, to me, reminds me more CHF, but not impossible. Remember with DVTs, they're gonna have that dividing line. You're gonna see that red point. Question? Okay. You're gonna see that red line on the leg. That's gonna be the point of clot, because everything south of that clot that's red is pooled blood. Okay? Questions on cardiovascular changes? Okay, so MIs, heart attacks. You guys talked a little bit about them with Cody, but the classic signs of a heart attack are often not present in geriatric patients. There are a few demographics that make MIs harder to find. Geriatrics being one of them, diabetics being another, and then women. And the reason these three are here is because their presentations can vary. It's not your standard, my left arm hurts, my jaw, my neck, my back, I'm having chest pain that feels like pressure. It can be different. When I was in high school, there was an older gal who was a front desk staff. She was complaining, I was an office assistant, so I talked to her quite a bit. And one day I came in and she was just complaining. She's like, yeah, my lower back is really bothering me today. I was like, you're old. Yeah, that checks out. Like, that was my mindset, right? I'm a senior in high school. Yeah, it turns out she was having a heart attack. That was her MI presentation was lower back pain. So they present a little bit differently. And then on top of that, these people will start to have what we call the silent heart attacks. In a more technical term, they're called NSTEMIs, non-ST elevated myocardial infarctions, meaning that even with an EKG, I can't see these, okay?
Non-STEMIs?
NSTEMI. So a STEMI stands for ST elevated myocardial infarction. That's when we look at the EKG, we'll see the big old tombstoning. With these, you don't see them. They look normal, but they can still have that clot presenting. And it's the size of the clot more often than not, and then where in the vasculature it is. But these older people have a higher likelihood of getting one in there, just because of the way their body's broken down. So a little interesting. It can make it a lot tougher. This is why just, generally chest pain, we can't just rule out MI mentally, especially if they're older, right? Remember what I said about presentations. They can have odd presentations that don't really match the textbook ones, okay? So some manifestations of acute heart disease: difficulty breathing, maybe stomach and abdominal pain, loss of bladder or bowel control, okay? We call this incontinence. Nausea, vomiting, weakness, dizziness, lightheadedness, syncope, I'm gonna come back to that. Fatigue or confusion, okay? Now, with these ones, anytime we see any patient, weakness, dizziness, lightheaded, passing out, right? That's syncope or syncopal episode is a passing out episode. We gotta double check their cardiac function. And if we think about it, it makes sense. All of these present because the brain is not being perfused, okay? Well, if the heart is not beating well, it's not getting blood where it needs to be, okay? So anytime you see those, these should be red flags in your mind of, okay, let's check heart function, okay? And then other signs and symptoms, issues with circulation. So you may see like, oh, my hands get really cold. That could be an example of that. Diaphoresis, excessive sweating. Pale, cyanotic, or mottled skin. Remember mottled skin when I showed you the peds? They kind of have that squaring pattern on them. Abnormal or decreased breath sounds, and then increased peripheral edema. Their feet are going to get more and more swollen. Now, I wouldn't use that last one, the peripheral edema. I wouldn't use that as the confirming sign, but it may be a question worth asking to kind of add to our suspicions. Are your ankles normally swollen? Yeah. Are they normally this big? No. Okay, that's a red flag, right? Start paying attention to the detail stuff. Questions on heart attacks and geriatrics? Cool, moving on. Heart failure, congestive heart failure, CHF. So the signs and symptoms will differ depending on whether the right or the left side of the heart is not functioning correctly. Now, typically when we think about heart failure, it usually starts with left-sided heart failure. The left side, what does the left ventricle beat to? Where does that send blood? The rest of the body. So if we can't send blood forward to the rest of the body, it starts to back up. Backs up from left ventricle to left atria to the lungs. Well, now the right side of the heart is trying to beat against an excessive amount of pressure that's built up in the lungs till eventually that blood starts backing up to the right ventricle, right atria. Now that heart is working so much harder than it has to for very minimal output, which is why the right side tends to follow, or excuse me, right-sided failure tends to follow left-sided failure. So right-sided heart failure occurs when the fluid backs up into the body, right? So right side sends blood to the lungs. If it can't get blood there, it's going to back up. So we might see that JVD in their neck. We might see ascites. I'll come back to that one. Peripheral edema, so swelling in the feet and hands. Enlarged liver. And then right-sided heart failure often caused by left-sided heart failure. So it's common to see signs of both. Okay. Now, does anyone know what ascites is? Ascites is, you typically will see it with like liver failure or, liver failure being a common one, or even hepatitis. But essentially it's where the stomach starts to fill with fluid and will distend because of that fluid buildup. And with the liver ends up putting out fluid, which causes it. To Google.
Why is the liver kind of impacted by CHF?
Say that again?
Why is the liver,
the portal vein. So we're backing up blood to everything, and so the liver, whose job is to filter the blood, is also being backed up. So it's working harder and harder and harder to not be able to push blood forward because the heart's backing up. Good question though. So ascites, ascites is essentially, they start to fill with fluid. This is what an ascites stomach looks like. It's distension of a whole different ball game. I've had the chance to, see, it's not quite like a beer gut, right? If we think about like the beer belly, it's not fat. This is, their stomach is so distended because it's just full of that fluid.
the stomach itself?
It's the peritoneal cavity. The stomach cavity, rather, or abdominal cavity. Here's another, right? So you can see that buildup, that distension. I've only ever seen this, truly this severe one time, and it was in the hospital, and they did what's called the tympanic test, so they tap on them, and it literally sounds like you're hitting a drum. Yeah, go ahead.
Yeah, that was what I was wondering.
Yep, the tympanic testing, you'll just thump it with your fingers, and it sounds like a drum in there. It's pretty crazy. The lady I saw it on was a chronic alcoholic, liver failure, the classic signs. Okay, so when left-sided heart failure happens, fluid backs up into the lungs, okay? So causes a condition called pulmonary edema, which is also going to cause shortness of breath. So what lung sound are we going to hear? Crackles or rails, What's our treatment for CHF if we have crackles or rails? CPAP. Yeah, very good, CPAP. So the patient will have shortness of breath, hypoxia with crackles in the lungs. They have a fluid buildup. Left side's failing, fluid's backing up to the lungs. They might also, this we see a lot more in the older demographics, have what we call paroxysmal nocturnal dyspnea. They have a harder time breathing at night because of this CHF, which once again has to do with gravity and how we position ourselves when we sleep, right? Gravity, if we lay flat on our back, gravity is spreading that fluid evenly across our lungs. If we're sitting up, tends to pool down in the bases, okay? This is one that, so characterized by a sudden attack of respiratory distress that wakes the person when he or she is reclining, okay, when they're lying flat. Caused by fluid accumulation, patient will will cough, feel suffocated, cold sweats. We'll notice tachycardia, but that's usually an anxiety response, right? If you wake up out of the middle of the night and you're not breathing well, probably gonna panic. But these people start to sleep more and more in recliners. Does anyone know anyone like that? The older folk, they only sleep in their recliners. It's because they have fluid buildup in their lungs. So if they're lying flat, it's harder for them to breathe. So in the recliner, they can at least sit up, and it keeps them in the bases. Very, very common finding. Questions on that at all? Okay. So strokes, leading cause of death in older people. Okay, so preventable factors versus uncontrollable factors, right? Some things you can change, some things you can't. This is where the consequences of your actions in your youth start to catch up to you a little bit. So preventable risk factors: smoking, hypertension, diabetes, AFib, obesity, sedentary lifestyle. All of those are something you can do something about as a prevention. Things you cannot control: age, race, and gender. It's kind of what you're stuck on, okay? I get myself in trouble, so we're moving past this slide. So signs and symptoms of a stroke. Well, first of all, what's our assessment? What are we doing to look for a stroke?
Be fast.
Be fast, yeah. Balance eyes, face droop, arm drift, slurred speech, and then what's the T stand for?
Time.
Time, yeah, time's of the essence with strokes. We want to make sure we get them to the hospital before their brain starts to die, okay? But some signs and symptoms: acute, altered level of consciousness, depending. Numbness, weakness, or paralysis on one side. Slurred speech, difficulty speaking, visual disturbances, headaches, dizziness, incontinence, seizures, right? Now, all of these, outside of maybe the paralysis on one side, all of these could be several different things. Okay, that's why I told you with the altered mental status, what are the two things we have to double check if we have an altered mental status patient? Blood glucose, and what else? Stroke assessment. Just rule them out, right? Check a sugar, check and see if they're having a stroke. If they're not having those two things, then we can start working our way down a different mnemonic. AEIOU tips, right? We can work our way through that one. Why are they altered? Now, hemorrhagic strokes, less common, but more fatal, more likely to be fatal when it comes to older people. This is where hemorrhagic strokes often appear similar to brain bleeds, because they're both kind of a similar problem. Blood is in the head when it shouldn't be. Hemorrhagic strokes typically are more physiologic in nature, but not to say that trauma can't lead to one, okay? And then remember, ischemic strokes occur when a blood clot blocks the flow of blood to a portion of the brain, okay? Ischemia, we can have ischemia in the three big spots: lungs, heart, brain, okay? PE, strokes. So our goal for strokes: salvage as much of the surrounding brain tissue as possible. Okay, so getting them to the hospital. These tended to be ones that I would see these literally out of my 3 shifts a week, I would see minimum 1 to 2. Okay, very, very common call type, to the point where a lot of us out there kind of make it a game of like, well, how fast can we get them there? And so personal best, no big deal, 10 minutes. But yeah, so try and top that. But if symptoms occurred within the past few hours, the patient will be a candidate for stroke center therapy. This is that clot busting medication, okay? TPA is typically the one they'll use. And then remember, TIAs can present with the same signs and symptoms as a stroke. What's the difference between a stroke and a TIA?
When TIA resolves within 24 hours.
Bingo, yep, TIAs self-resolve within 24 hours. Very good. Now for us, are we gonna know the difference between a TIA and a stroke? Probably not. Very good. So let's talk about some nervous system changes then. So changes in thinking speed, memory, and posture stability are most common findings. Okay, so the brain, kind of like when we talked about alcoholics, how when people become alcoholics, their brain atrophies and gets smaller. Same thing happens as we get older, okay? Your brain gets a little smaller, it atrophies, which then puts tension on all of the vasculature in your head, because the brain's smaller, still connected to the skull, so there's a lot of tension being held between the two. And that's not to say, because you can be a geriatric and an alcoholic, right? That's a double down. Those people are at increased risk of brain bleeds because of that, okay? Now, depending on life choices, 5 to 50% loss of neurons in older people, so how their brain functions. And the performance of most of the sensory organs also starts to decline with increasing age. Okay, we'll talk about them, but has anyone ever walked into an older person's house and been like, it is unbearably hot in here? That's very, very common. They start losing that, their skin loses that sensation ability, so they're pretty warm in their house all the time, okay? So some changes, so vision, visual acuity, so their sharpness changes, depth perception, ability to accommodate light change with age. This is where like a lot of older people stop being able to drive at night because their night vision is getting worse. Okay, and then depending on how old they get, their vision and kind of genealogy a bit too, they can start having cataracts, What are cataracts? Does anyone know? Think of that like,
Film, isn't it?
yeah, that film over your eye. Think of like a really, this is gonna sound kind of mean, but think of that really old dog that should have been dead like 5 years ago and it kind of shakes and its eyes are all hazed over. Those are cataracts.
What is it?
It's basically a buildup of hyphema, like a tissue, that'll eventually just starts connecting and clouding the vision. It's clouding that front lens.
Connected floater. Does it move?
The cataract, when they're considered cataracts, it's basically the floaters have basically grabbed onto each other to such an extent that they're not floating. They're now a film. Yeah. Yeah. They also have decreased tear production, which leads to drier eyes. They'll also get those, I don't know how else to say it, but like eye boogers a lot worse too in that corner. But vision changes are very, very normal. I'm sure you all have, or it's not all, but some of you have parents already. You hand them, you're like, look at this thing on my phone, and they do like this number, you know? That's because their eyes change shape as you get older. That's a natural thing. That's why a lot of older people wear those cheater glasses, the little reading glasses. It's a common changing. Now, they also may have the inability to differentiate colors depending on the loss of whatever receptors, right? There's rods and cones. Rods help us see light, cones help us see color. So if they start losing cones in their eyes, they might lose the ability to see certain colors. Same thing with rods. If they lose enough rods in their eyes, their night vision gets worse because they're unable to pick up as much light, okay? So they start developing the inability to see up close. That's presbyopia. Presbyopia, that's gonna be that needing of cheater, those little reading glasses. And then other diseases, glaucoma, macular degeneration, even retinal detachments, all potential. Some of these are going to be more genetic based. Yeah. Questions on vision changes at all?
With retinal detachment, what happens?
So in retinal detachment, the back of your eye, the retina is basically that first layer of the back of the eye. It starts to separate, the layer starts to separate. And it's often seen in trauma, people hitting their head is when we see it more frequently.
Does it cause any?
Because it causes what?
Like, do they go blind?
Oh yeah, they'll go blind. You'll lose your vision. That's why, like, you ever see Rocky growing up? When he starts losing his vision after getting punched so many times, that's retinal detachment. Yeah. Yeah, and the macular degeneration is the breakdown of that same area. Instead of it being detached, the retina being detached, it's basically the retina in the back of the eye is just degrading away. So they lose vision that way. And the glaucoma, oma means mass. Glaucoma is a tumor in the eye. I had a roommate in college who had it, and one eye was like noticeably bigger than the other. So, yeah. So hearing, that also starts to change. So changes in our inner ear makes hearing high frequency sounds difficult. Okay, there's these little kind of hairs in your ear. And once those hairs, because those hairs pick up vibrations, and that's what helps the bones vibrate in our ears, right? Those three teeny tiny bones. Well, you start losing those little hair-like appendages, you start to lose the ability to hear sounds, or especially like high-pitched sounds. So you know those like ringtones, that's like the really high-pitched sound, and like teacher can't hear it, so everyone, I don't know, maybe you guys didn't do this. When I was in high school, that was the thing. They'd have this ringtone that would go off, and it'd be like a mosquito talking, but only the kids could hear it. That's usually, if you cannot hear that anymore, you started to lose your hearing a little bit. It's just a natural thing, it happens. But they also develop problems with balance, right? Depending on the eustachian tubes, the connecting tube from the ear to the nose that helps with our balance, that can start being disrupted. They can have presbycusis, which presbycusis is gradual hearing loss, not an uncommon finding, okay? And then hereditary and long-term exposure to loud noises are the main factors that affect people's hearing, okay? A lot of it is hereditary. Another one is if you choose to be, just making it up, a roadie for a band and you've done thousands of concerts and you never wore hearing protection, there it is. Or if you're somebody who shoots lots of guns and you don't put hearing protection on, there it is. It's gonna catch up to you eventually. Taste starts to wither away. So the number of taste buds they actually have present start to dissipate, okay? Now this can lead to some negative results. So big one being they have less interest in eating, right? So 'cause people eat things because they taste good. That's why you have your favorite foods. You like the way they taste, maybe a bit of texture too, but digressing. Well, if you can't taste, things like weight loss start to catch up because you don't eat as much. Malnutrition starts to show up because you're not eating as much, once again. And then complaints of fatigue. Our body doesn't have part of the fuel it needs to function, right? The glucose. So it starts to play a role, right? It can become a systemic change, or excuse me, a systemic effect because of an isolated change. And touch. Decreased sense of touch and pain perception from the loss of end nerve fibers. Especially people who get like really bad sunburns repeatedly, they start to kill those nerve fiber endings at a certain point. Okay, now older person may be injured and not know it. They also have that decreased sensation of hot and cold. I don't know about you guys, but my grandpa, those last few years that he was kicking, he used to cut his arm all the time. Like, he'd be like, "What did you do to your arm?" He's like, "Would you look at that? I have no idea." They just can't tell. Okay, they also have thinner skin, which we'll get to. Their skin gets more of like a paper-like consistency because it loses the elasticity, so skin tearing is a very common thing we see. But they have the decreased sensations of hot and cold, which is why we see a lot of hot and cold emergencies in geriatrics. They can't tell that they're getting too hot. They can't tell that they're getting too cold, which is why a lot of their houses are so hot because they just assume I'm probably cold. It's the way it works. Questions at all? Okay. Okay, let's get into dementia. Now dementia, not everyone has it, right? Don't just assume because they're old they have dementia. What it is, a slow onset of progressive disorientation, shortened attention span, and loss of cognitive function. Okay, now dementia is kind of an umbrella term. It's a bit of a condition, but there's kind of several factors that fall under as dementia, and we'll talk about those in a moment. Now it's chronic, generally irreversible condition that causes progressive loss of cognitive abilities, so your critical thinking, psychomotor skills, your ability to control your own body and space, and then social skills, which a lot of time in my experience with dementia patients, a lot of them end up reverting back to, and this is a bit of Alzheimer's, but they revert back to different time frames in their lives. Well, if I'm talking to someone, it's 2024, and in their mind it's 1980, we're talking about very different lives, right? We're having very different conversation, different perspective. So social skills do tend to kind of falter here. Fun fact, maybe not a fun fact, to tell if you're a potential dementia, if you're going to inherit dementia, you have to catch it early. And when I say early, like you have to find the gene by the time you're in your 40s, which not many people in their 40s are thinking about dementia. That's an older person's condition. So it's kind of one of those hidden things that if you don't get yourself checked, you could run into it. What's his name? The guy who played Thor, the Hemsworth. The reason he stopped acting is he got tested for it. He has money, so that helps. But he got tested for it, and now he's getting kind of treatments and trying to reverse this, right? That was a big portion of it. You got to catch it super, super early. Now, like I said earlier, dementia is the result of many neurologic diseases and can be caused by a few different things. Alzheimer's disease, Parkinson's disease, CVAs. I want to know another word for CVA. Cerebrovascular accident or attack. It's a stroke. Heart attacks are MIs. Strokes are CVAs, cardiovascular accidents. I would know that verbiage. Okay, that one does pop up. And then genetic factors. So Alzheimer's tends to be a memory change thing, where that's where the one with Alzheimer's where they typically will go back into that different time of their life. Parkinson's, I don't know if you guys, it reminds me of Michael J. Fox every time, right? They get shaky, they have the breakdown of the neurons there. And then brain damage, obviously, from CVAs. Yeah, I have a story I'll tell after this one. So on assessment, patients may have short or long-term memory loss, okay, just depending on how bad it's gotten. They're gonna have a decreased attention span. They may be unable to perform daily routines. They may show a decreased ability to communicate. They might appear confused or angry, have impaired judgment, be unable to vocalize pain, okay? So kind of like concussions, when I was telling you guys concussions, they do that like 5-minute reset loop. I've had several dementia patients, more Alzheimer leaning, that get that same way. One gal, she's one of my favorite patients ever. She was so feisty. We show up, she fell, not acting abnormal. Hospital, or staff wanted her to go to the hospital. So I was like, all right. So as we're taking her, she's like, I should probably call my parents and let them know where I'm going. And she's 96 at this point. So it's like, if they're still alive, no, what's their secret? They know something we don't know. And then she's like, oh, these are the wrong slippers. I'm wearing my house shoes. I want to wear my going out slippers. Like, yeah, I'm sorry. Well, kind of like concussions, like I said, it's gonna be that feedback loop. And then she was telling me what her dad did too. And she's like, oh, I should probably call my parents in the back of the email. It's like, oh, your dad, he's a lawyer, right? She's like, how do you know this? I don't know, just paying attention. And I was like, oh, those look like the wrong slippers. She's like, yeah, these are my house shoes. How do you know? And then it's another 10 minutes and it's the same game over and over and over, okay? It can be fun from time to time. Obviously, don't be abusive of that by any means. But it does show up. That short-term, long-term memory loss starts to really show up. In her mind, it was like 1960 something is what she was telling me. She grew up in California. She was on the beach in her mind. We're not there very clearly. Another thing is unable to vocalize pain. This one can be difficult, especially if we're dealing with trauma. I've had a few dementia patients where they fell down and anywhere you touch them, they'd scream, ow. It's hard to assess someone if you touch them anywhere and they say, ow. One patient in particular really could not tell what was going on with her, ran her in and she ended up dying 2 days later of something related, but she had a hip fracture. And I was unable to tell because I didn't know what hurt on her. So at a certain point, you just got to assume, let's just take general care, let's move them slow, let's just get them to where they have to be. We can't fix everything, right? There's nothing we can do to fix that hip fracture. It's hard to even control pain. I wasn't going to give her pain meds because once again, I didn't know what really hurt. And it's not that I didn't trust her, I can't rely on my own ability.
Put a pelvic binder on her?
I could have, yeah. There's no indicator though, so that's why I was like, because normally they have the shortened and laid down foot. Nothing. Yeah.
How do you call that in?
I just called it in as a fall patient, generalized pain, unable to get an exact location because of the dementia history. Yeah. And it's not an excuse, it's a reason, right? It's a genuine reason why I couldn't do what I wanted to do. Questions on dementia? Cool. Let's take 10-minute break. We'll come back at 8-minute break, 9:10. Let's keep this moving. So we just talked about dementia. Let's get back to delirium. So delirium, sudden change in mental status, consciousness, or cognitive process. Typically in my experience, once again, these people, I think of them as more of like the ramped up patient. These people, in my experience, have been a lot more kind of agitated with a lot of things, but I digress, we'll get to it. So marked by the inability to focus, think logically, and maintain attention, affecting 15 to 50% of the hospitalized people over 70. They will hit some variation of delirium. And then a lot of times there's an acute anxiety with it as well. So they're stressed out and that's throwing them into this kind of agitation state. Kind of backtracking to dementia, a lot of these people become really, really routine oriented to the point that if you disrupt their routine, it can make them pretty pissed off, which delirium oftentimes will follow that kind of agitation, especially if we have dementia patients. Delirium is not its own condition, it's kind of a step of the condition or progression. Okay, so generally the result of a reversible physical ailment such as tumors, fevers, or metabolic causes. In the history, look for withdrawal from alcohol or sedatives, right? The reason those are on there is those are just typically the hardest ones to kind of kick when we talk habit-wise, because they are physiologically addictive. So it can also have some brain degradation as well in there, right? As I was talking about with alcoholism, it can atrophy the brain. Different medical conditions, depression, malnutrition, or vitamin deficiencies. If you look through because with most patients in like a nursing home type setting, they'll give you what's called a face sheet. So it has all their information, the meds they take, their medical history. If you're looking through their medications and it's like vitamin A, vitamin B12, vitamin C, and there's lots of like additional meds or vitamins in their meds, that's indicative of deficiency more often than not. Environmental emergencies as well. A lot of these people, older people, think dementia getting trapped outside, right? If it's hot, if it's cold, problems can arise. Now, assess and manage the patient for the 4 H's: hypoxia, hypovolemia, hypoglycemia, hypothermia. Okay, these 4 H's can help guide us towards relieving this delirium. Okay, and then you may see changes in circulation, breath sounds, motor function, and pupillary response. That pupillary response is a dilation. They usually get a dilation when they hit that delirium. The last case of delirium I saw was a guy who was a dementia patient, was just getting moved into a new facility, and he didn't obviously know that facility. It broke his routine, and he was really upset. When we got there, his son, basically him and his son had gotten into a physical altercation. The son wanted to put him on a psych hold. He didn't meet qualification for a psych hold. But we were able to talk him down and get him to go to the hospital. But this guy was just like rage walking around this facility in his little tighty-whitey underwear, and he was mad, boy. So getting them to de-escalate or getting them to calm down as best you can, but end of the day, get them to where they need to be. These are older folks that I don't want to say you will use restraints for, but they could meet qualification for. Yeah.
So would you say that they're more leaning towards like excitable?
Yeah.
Or aggressive?
Yep. Depending on the person, I'd say it's kind of it's a 50-50 more so. Yeah, depending on kind of their temperament at baseline, I would say. Questions on delirium at all? Cool. Moving on to syncope. So remember, syncope is just passing out, okay? People don't just pass out for no good reason, so assume this is a life-threatening problem until we prove otherwise, okay? And then often caused by an interruption of blood flow to the brain. Like I said, with syncope and syncopal episodes, we need to double check cardiac function, double check pressures, make sure the brain is perfusing. And I'll let you spend time in this table on your own time. Now, neuropathy. Neuropathy is a nerve disorder. So disorder of the nerves in the peripheral nervous system. Essentially, those nerve endings start to kind of, I don't want to say wither away because it's not quite entirely accurate, but they give abnormal sensation. Okay, they give that sensation of like, from what I've heard, the pins and needles type feeling. Okay, but it's a constant. It's not a positional thing like it is for most healthy people. Now, the function and structure of the peripheral motor, sensory, and autonomic neurons are impaired. And the symptoms depend on which nerves are affected and where they're located. We typically see this, in older people, but we typically see it in like diabetics in their feet. Remember that story I told about that diabetic who stubbed his toe? Couldn't even feel his feet, right? That's that neuropathy showing up. So it really depends on which nerves are affected, and it tends to be either feet or I've seen it in the hands and arms quite a bit, which if we think back to, anatomically, the nervous system, we have the brachial plexus, that big nerve set in our shoulder, and then the sacral lumboplexus or lumbosacral plexus in our tailbone, right? So it can happen from branches just off of that. So there's big branches of nerves that can start to kind of impair that sensation south of the bundles. Questions on that at all? Okay, let's get into GI. So a couple of things, right? We already know they lose taste buds, so they don't taste the food, so they don't eat as much food, right? But on top of it, there's a reduction in saliva. Well, remember, saliva is really important to our digestion. Saliva is the chemical breakdown. That's where it starts to break down in the mouth. As people get older, they tend to lose teeth too. That's not an uncommon thing, which once again, pro tip, if someone doesn't have their dentures in, take the extra time to put them in. A lot of people are harder to understand. Take the time. It's the same thing. If they need their glasses, take the time, find their glasses. They need their hearing aids. Trust me when I say you want them to have their hearing aids. Put them in their ears, okay? Gastric secretions are reduced, so they don't have as much stomach acid. They have changes in their gastric motility. Motility is basically a fancy word for saying like the movement of stool, how their body progresses and moves that waste product out, so that peristalsis, right? Peristalsis starts to slow. So things like bowel obstructions are pretty common in older people, okay? Because they're just not moving that stool out. Incidence of certain diseases involving the bowel increase. We tend to see more of bleeding, GI bleeding tends to grow there. Things like diverticulitis, and then those bowel obstructions, which bowel obstructions can become what they call impactions when things start to really build up behind that blockage. And then blood flow to the liver declines, right? So they might have a harder time processing things like alcohol or their medications, depending. So some more changes. Issues with dental problems, decreased saliva and sense of taste. Poor muscle tone between the esophagus and the stomach and that sphincter. So what do you think they're going to experience more often? If that sphincter between the stomach and the esophagus is weaker.
Acid reflux?
Yeah, acid reflux more frequently. Decrease in hydrochloric acid in the stomach, like I was saying. So that's going to follow in with the alterations in the absorptions of nutrients, right? Because they're not chemically breaking their food down as well. So they're not getting as much nutrition out of it. Okay. And the weakening of the rectal sphincter, incontinence of stool. It's not an uncommon thing as people get older. Which is why I like Depends. Depends are the grown-up diapers. A lot of them wear that. Chris has described it to me as, well, not Chris necessarily, but I've heard it described by several people of, you know, we start as babies and we end as babies. It's just kind of the way life progresses. So GI bleeding can be caused by inflammation, infection, or obstruction. And remember, we can have upper or lower. So upper, we're going to have that hematemesis. Can someone tell me what it looks like? Coffee grounds. Yeah, coffee ground emesis for upper. If we're worried about lower GI, what are we worried about? Or what are we going to see? Melena. Can you describe it for me? What's melena look like? Huh?
What?
Dark tarry. Dark and tarry. Think that. Okay? And remember, there's a difference because there's going to be, if we see bright red blood, we're worried about hemorrhoids. Okay? We want to know the differences. Dark and tarry stool, lower GI bleed, melena. Okay? Bright red blood, hemorrhoids. Not an uncommon thing. Which I was actually watching a post that a doctor put up the other day about how sitting on the toilet for an extended period of time causes pooling of blood to your rectum, which causes hemorrhoids. So sitting on the toilet too long is a problem. Well, sometimes these people have weak enough legs they can't get themselves back off. So if they're stuck there for extended periods, hemorrhoids are not off the table. Okay? And also for yourselves, don't sit on the toilet for too long. But patient with GI bleeding may also experience weakness, dizziness, syncope. We are not circulating blood. We are losing blood that should be going to our brain. It's going other places now, which is when you'll see the weakness, dizziness, syncope. So remember, these are not just nothing terms. If they say, yeah, I'm feeling kind of weak, I'm feeling kind of dizzy, look into it, okay? Specific diseases, so diverticulitis, kind of talked about it, how they'll get those little whatever, they have a hard time digesting, will get caught in the bowel there and inflame the area, and if it gets really worse, it can fistulate into other portions of the bowel. Upper or lower GI bleeding, peptic ulcer disease. Can someone tell me where a peptic ulcer is? In the stomach. Peptic means stomach. So this is an ulcer in the stomach. Remember, an ulcer is where they start to wear away that mucus lining. Now acid is touching the organ itself, okay, usually causing bleeding and pain. Gallbladder disease and then bowel obstructions are common. Okay, so gallbladder can either be production of stones or it can have cholecystitis, right? The inflammation of the gallbladder there, just depending. Now, when assessing the patient, ask about NSAID and alcohol use. Why do you think we're talking about this? Why do you think we care what their NSAID and alcohol use looks like? Because what?
Higher likelihood of it impacting the liver and the stomach?
Not so much the stomach, but I think you're on the right track. Let's see, where did I see it? It was the liver. Yeah, the liver, because of the potential of the liver being weak, we want to know, do you drink alcohol? Do you use a lot of NSAIDs? Because those are processed through your liver. And if you have a weak or bad liver already, you're just making it work harder and harder and harder. Okay? Orthostatic vital signs, pretty important. We'll talk about those in a second. I'll come back to them. Those can help determine if they're hypovolemic or not. And then treatment, ABC, supportive care. Orthostatic vital signs, okay? What these are is we take blood pressures in different positions. So while they're laying down, take a blood pressure. While they're sitting up, take a blood pressure. When they're standing up, take a blood pressure. And this can all be done within several minutes of themselves. The reason we do that is gravity. If we're laying flat and we have a blood pressure of 120, we sit them up and now it's at 110, and then we stand them up and now they're at 95. That's a positive orthostatic sign. They're probably hypovolemic at that point for one reason or another. Vomit, urine, stool, diarrhea, whatever, okay? But that's a good indicator that they have a low fluid in the tank, right? Remember pumps, pipes, fluid? They have a low fluid amount. Yeah?
Are you gonna make geriatric patients do that? I mean, like if they're not super mobile.
Oh, well, I mean,
have them.
situationally, but that's where we can do like laying down to sitting up, right? That's where the difference is. If there's someone who's not mobile, you're not gonna be able to test it, really. But you can use these for everybody. Orthostatics are great for everyone. Mm-hmm. Yeah, they talk about it most with older folks. I would encourage you guys to get orthostatics as best you can. It's a really good indicator. Also, you'll start to see that compensation sign. The blood pressure drops, pulse will go up. Right, so 90 systolic as they're standing with a pulse of 110, they're compensating for hypovolemia. Okay? Questions on it? Cool. So the acute abdomen, remember with the abdomen in general, we are not going to be diagnosing anything. We're not fixing any problems, but we need to know is this, or what we need to be good at rather, is this going to be a life threat, yes or no? Okay, so extremely difficult to assess in the pre-hospital setting, right? There's a lot of things going on. We don't have imaging, blood work, XYZ. So the most serious threat from abdominal complaints is blood loss, hypovolemia, and then remember the AAA, abdominal aortic aneurysm is one of the most rapidly fatal conditions, right? Anytime we have an aneurysm, especially an aortic aneurysm anywhere on that tube there, it's problematic, okay? Talked about it, so I'll mention the first sign, right? The differing blood pressures. How are they gonna describe their pain if they have a abdominal aneurysm or aortic aneurysm? Huh?
Tearing.
Tearing, you gonna use another word for me? Shearing, what's another word? Ripping. That was the big three I was looking for. Tearing, shearing, ripping. If they say any of those three words, we should be thinking aneurysm. Things are splitting apart, okay? Alrighty. Any questions on GI at all? Then moving on into the renal system. So age brings changes to the kidneys. So there's a reduction in renal function, so they don't clean out the blood as effectively, okay? So there's a reduction in renal blood flow. There's less blood even getting there half the time. And then you can have what's called tubule degeneration. So inside the kidney itself or inside the ureters, you start to get that breakdown, which then leads to potential infection risks and XYZ, almost like aneurysm through the kidneys. Now, changes in the genitourinary system. You have decreased bladder capacity. Old people pee a lot because their bladders are smaller. They have a decline in sphincter muscle control. This is one where you can have inverse problems. You can have incontinence because of this poor control. You just can't control it and the fact that it just lets itself go. Or you can have the reverse problem. They can't relax and now they can't pee, okay? Which I'll come back to that. Decline in voiding senses. Voiding means to urinate, okay? Voiding is urinating. And then increase in nocturnal voiding. So this is a lot of jokes, especially if you're around older men. They love to make the joke of like, well, I'm an old man, so I'm gonna get up and pee 3 times tonight. It's not an uncommon thing. And then it's also not uncommon for, in men specifically, benign prostatic hypertrophy. The prostate gets large. And meaning benign as in it's not like a cancerous region, it's just a natural growth of the prostate, which pinches off the urethra, essentially making it more difficult to urinate. I had one patient who, I mean, there's a lot to this story, but he couldn't pee. He hadn't peed in like 32 hours or something, and he was incredibly uncomfortable. And I believe it, okay? So just because, I know it sounds kind of silly, but if they can't pee, that is a problem. Okay, that is a waste product that they can no longer get rid of. And then put yourselves in their shoes. Imagine having to pee super, super bad and then just not being able to, okay? Now, incontinence is not a normal part of aging, okay? Now, it can lead to a few things like skin irritation, skin breakdown, or UTIs. I'm gonna come back to potential reasons. Now, there's 2 types of incontinence that you guys will encounter. There's stress incontinence and urge incontinence. Stress incontinence happens during activity. So coughing, laughing, sneezing, lifting, exercising. This is something that also happens with pregnant women as well. You know, they cough too hard or they laugh too hard and they pee a little bit. That's a stress incontinence. They're doing something that forces it out. On the flip side of that, there's urge incontinence. So hot or cold fluids, running water, thinking about going to the bathroom. This is the example of like, think of a waterfall, 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 and then they have to pee. That's urge incontinence. Now back to the skin irritation, breakdown, and infections. A large demographic of geriatrics we see are in nursing facilities, okay? Assisted living homes. Not all of them, but a lot of assisted living homes are not the greatest, okay? Just like everywhere in medicine, they're short-staffed. They don't have the hands to provide these people with the care they necessarily need, which is why, especially around our area, there's a lot of turnover in ownership because people get mad that their family's not being taken care of well, but I digress. Well, if there's a lesser amount of CNAs or staff available to help, this person could be sitting in a diaper, say they get a brand new, it depends, they urinate and they don't get checked on for 3-4 hours. That's just sitting on their skin, okay? Well, it's a waste product for a reason. We get rid of it. So it can start to irritate the skin. If it stays exposed long enough, it can start to break down the skin layers, okay? And we'll talk about another one, version pressure sores, in a little bit. And then same thing is that with UTIs, if they urinate in that dependent, they're sitting in it for hours and they have that bacteria, that can definitely go up the urethra, okay? UTIs, especially in men, go up when it comes to depends and things like that. Same with women, and older women, in fact, are probably the most frequently seen demographic of UTIs. So they're gonna have that mentation change, they're a little bit altered. You might notice a very distinct smell. It smells like a dirty cat box. Very obvious, okay? Now, the opposite of incontinence is urinary retention or difficulty urinating. So like I kind of mentioned, right? If in men, enlargement of the prostate can place pressure on the urethra, making voiding difficult. They're basically kinking the urethral tube. Bladder and UTIs, also common. They can cause inflammation, okay? They swell up, things get tighter, you can't pee. And then severe cases of urinary retention, patients can actually go into kidney failure. So think about it kind of like from a similar mindset, I guess, to the heart. If the heart can't beat forward, it's going to start going back. Same thing with our bladder. If we can't urinate, eventually that bladder is going to get so full, it's going to start backing up to the kidneys. And then we put the kidneys at risk of infection at that point as well. Questions? Okay, moving on. Endocrine, so this is one, once again, these are some really, really smart cookies who are endocrinologists. I'm not one. So we're gonna go through this kind of at a surface level perspective. So reduced thyroid hormones, thyroxine. I'm sure some of you have heard of, oh, I have an underactive thyroid. That's not an uncommon change in older people. So some signs, symptoms, heart rate slows, they start feeling fatigued, their skin gets dry, their hair gets dry, they are not as tolerant of cold. They don't do as well in abnormally cold temperatures. And then they'll start to gain weight. And that's because they're no longer, essentially they're not regulating their body from a hormone perspective as well. So they pack on weight. That's usually a sign. Now, other changes. So an increase of secretion of the anti-diuretic hormone causing a fluid imbalance. So for your guys' knowledge, a diuretic, this portion right here, a diuretic is a medication we can give, but a diuretic makes you pee. Okay, so for example, caffeine. Caffeine is a natural diuretic. If you drink an energy drink or a large coffee and you notice, oh, I gotta pee a lot sooner than normal, it's not just the fluid, it's the caffeine that's doing it. So they secrete more anti-diuretic, meaning they withhold, right? They're not urinating as frequently, so they start to have a fluid imbalance. They have too much, which once again, as we backtrack here, can lead to things like bladder infections and potentially renal failure. Hyperglycemia is not uncommon. Their sugar, right? If we've talked all about diabetes, but their sugar can start getting high. They have increased levels of norepinephrine, so in potentially harmful effects on the cardiovascular system. Can someone tell me beta 1, beta 2 alpha, what norepinephrine controls?
Beta 2.
What?
Is it beta 2?
Nope. Beta 2's lungs. Beta 1's heart. I'll give you that one. And then alpha's vasculature. Someone tell me which one? Norepi?
Alpha.
It's alpha. So it is alpha, but so epinephrine is beta 1, beta 2. Think about why we give it, right? Anaphylaxis, we want to make sure the heart's beating effectively, opening up the lungs, beta 1, beta 2. And then it was some alpha, because we want vasoconstriction. Norepi is primarily vasoconstriction. Okay, so what happens to our blood pressure with vasoconstriction? Goes up. So if we have an abnormal amount of norepi, this is another reason they can become hypertensive, okay, at baseline. HHNS, definitely potential, right? That kind of follows along with that high blood sugar. Especially as we talk about type 2s, sedentary lifestyle, right? They start putting on weight because they're not moving as much. It's kind of just a progressive problem, okay? Now on our assessment, if they're in that HHNS, warm flesh skin, poor skin turgor. The skin turgor is that elasticity of our skin. So they'll have that, remember that picture of the baby getting their skin stretched off their head? Same thing. Pale, dry oral mucosa. They might have a furrowed tongue. Okay, furrowed tongue is kind of where it starts to almost looks like their tongue is growing hair, for lack of a better description, and it starts to split a little bit. And the potential signs of shock, just depending. Now, what should we do? Get a blood pressure, check pulses, auscultate breath sounds, get a temperature, check a VG. This sounds like our typical care. Nothing that crazy, right? These are all things you're going to do on most of your patients anyway. And then once again, supportive ABC care. These people need long-term hormone regulation through medication, and we obviously cannot provide that. Okay? Questions on endocrine at all? Now, we talked a little bit about it. I want to make sure it's not. We talked a little bit about it with type 2. Remember, diabetes as well, they can also go into that hypoglycemia. Think about the natural changes. They don't taste as much food. They don't eat as much food as a result. So if they're diabetic, hypoglycemia is an uncommon finding as well. Okay? Changes in the immune system. So infections commonly seen in older people because of their increased risk. Their immune system just doesn't function as effectively as it did when it was younger. Cells are getting tired, they're getting worn down. So they're less able to fight infections. So then we start to see things like anorexia, fatigue, weight loss. That kind of comes with falls. Fatigue and weight loss, the weight loss you're losing is muscle mass. No muscle mass, you lose the ability to hold yourself up well, okay? You can have changes in mental status, those can be the primary symptoms. Pneumonia, UTIs are common in patients who are bedridden. So this is gonna think about the sedentary lifestyle. If they're bedridden, they can't get out of their bed. They have some sort of lung infection. Well, if they're laying flat, that's gonna take up more tissue space, okay? Same with UTIs, they tend to wear more Depends, or they tend to have, they put the Chuck's pads down underneath them, kind of like when we were doing the baby delivery, that blue and white pad. They'll have that down underneath them. Well, if they urinate in it and they are sitting in it for who knows how long, it can potentially cause infection. And then signs and symptoms may be decreased because of loss of sensation, lack of awareness, or even fear of being hospitalized. That's a pretty common thing you'll see with older folks. Especially like when I started working in the COVID era, hospitals are where people went to die. So people didn't want to go to hospitals because that's where the sick people live, okay? And even as older people in general, they don't want to go to a hospital because once again, that's where people die, okay? Questions in the immune system changes at all. Okay, musculoskeletal. So decrease in bone mass, especially postmenopausal women. Postmenopausal women, they lose that hormone production. Those hormones are part of what help keep your bones strong, which is why older women tend to have a higher incidence of osteoporosis, okay? So bones become more brittle, tend to break easier, and then as we've already discussed several reasons why, higher likelihood of falls. Higher likelihood of fall leads to higher likelihood of fracture. Joints lose their flexibility, and then a decrease in muscle mass often results in less strength, and then once again, less strength, higher likelihood of falling, okay? Something else that I think we need to consider is what kind of surgery do old people typically get on their joints? Replacements. Yeah, replacements. So if we're gonna be picking people up off the floor, maybe double check. Are these shoulders okay if I lift you from your shoulder? Because it's not uncommon to be like, oh, I had my right one replaced. Then we're not gonna yoink you up by your arms, okay? Same with hips. Hips, shoulders, knees, pretty frequently replaced. So changes in physical abilities can also affect older people's confidence and mobility, right? As they get weaker over time, they don't want to do things because the fear of getting hurt or injured goes up because they know their confidence is down because they just can't get around as well, okay? So muscle fibers become smaller and fewer. They have less motor neurons, so they're less responsive. Less strength. Ligaments and cartilage lose their elasticity, so they tend to tear a lot easier. And their cartilage goes through degenerative change as well, right? So their cartilage is not as soft and pliable as it is normally. It's resilient still, but it's not as soft or strong as it once was. And then kind of back to that confidence and mobility. For example, like my grandma's fallen too many times in the last 2 years. Now it's to the point where she doesn't even want to go outside and check her mail because she's scared she's going to fall down, right? You see how that confidence starts to become impacted at certain points. So osteoporosis, characterized by decrease in bone mass, okay, and the reduction in bone strength leads to greater susceptibility and fracture. Okay, I've kind of kicked this dead horse a couple times. Now, the extent of the bone loss depends on a few things. Genetics plays a role. Your body weight plays a role, right? If you weigh too much and your bones are getting weak, you're putting an abnormally large amount of stress on your bones themselves. Things like smoking and alcohol consumption, those can also break down the body. Typically, like carbonated drinks are not good for your bones either. And then level of activity and your diet. Motion is lotion. The more you move, the stronger you keep your body. The stronger your body is, the longer you live. I actually just saw a study talking about grip strength and how it correlates with longevity of life. And so they say over the age of 60 as a female, you should be able to carry in both hands half of your body weight. And then as a male, your total body weight for a minute. Typically, the longer... So like you're half your body weight. So if it's like, I'm just making up like half your body weight, 70 pounds, 35. Yeah. But half your body weight total in both hands. And if you can do that for a minute, the longevity of your life typically looks good, barring traumatic injury and things like that. So from like a perspective of things we can take care of to carry your body, it's the suit you wear your whole life, right? Osteoarthritis. Progressive disease of the joints destroys cartilage, promotes formation of bone spurs, leading to joint stiffness. Some of you may have already started this ball game. It's not a fun thing. You start to have the breakdown. Typically, if you've had like surgeries to replace injured joints, this tends to start following. On one of the plus sides, though, you do get the superpower of telling when it's going to be cold because all of your joints hurt before the cold fronts come in. So this is a result from wear and tear, just using your body, okay? And usually the joints affected are hands, knees, hips, and spine. And then that's kind of specific almost to the damage you've done throughout your life. What have you injured? What's at a higher likelihood? Questions on musculoskeletal changes? Cool, moving on. Changes in skin. Their protein that makes the skin pliable declines with age. I kind of talked about it earlier. They get that papery skin. Okay, their skin gets thinner, tends to tear a lot easier. They also have a thinner layer of adipose tissue under that skin, kind of like babies. Remember how babies don't have a lot of adipose tissue? So they're not as insulated. This is another reason they lose their temperature. Hot and cold emergencies affect old people and babies fairly similarly. They also are more common or more susceptible to bruising. Okay, so I'm sure you guys can think of an example of an older person in your life who bruises really, really easily. And that'll be doubled almost if they're on a blood thinner. If they're on a blood thinner and they're an older person and they bump their arm, their whole back of their arm could be purple, okay? Their sweat glands don't respond as readily to heat, so they overheat a lot faster, right? If we think about hot and cold emergencies, heat stroke becomes problematic when they stop sweating, right? Same with it's moderate hypothermia, right? They start to stop shivering. That's kind of a concerning point anyway, so these people already at baseline don't do that as well. So something we gotta be more cognizant of. Pressure ulcers, I'm gonna show some pictures here that might horrify some people, but pressure ulcers become a problem as well. Now, sometimes they're called bed sores, sometimes they're called decubitus ulcers, that's the technical term is decubitus ulcers. Okay, but it's the pressure from the weight of your body cutting off flow to the area of skin. So you're making portions of your skin ischemic, essentially, with your own pressure. Okay, and I'll give you an example, kind of maybe put it together. And then with no blood flow, a sore develops. I just want to see something. Okay, and I'll go through the next slide, then I'll show you pictures. So in your mind, put yourself in this situation. You're in a concrete situation. I don't know, everything's concrete around you, and you decide you're going to lay flat on the ground. You're going to be very aware after about 15 minutes of every portion of your bones touching that concrete, right? That pressure is going to start building up. You're going to become uncomfortable. Those are the beginnings of pressure ulcers of sorts. Okay, now this is another thing that comes down to these care facilities And even if you've ever had like a surgery where you've had to spend time in the hospital, they rotate your positions to make sure you're never in the same position for more than an hour because they try to avoid these sores. Well, if a facility can't provide the care to someone that needs the care, excuse me, they could be laying for hours in that same position, right? And even if it's on a bed, I'm sure you guys have all laid in your own bed and be like, "Oh, I'm pretty uncomfortable. I've been laying in this spot for a long time." It's the same kind of concept. Now, there are stages to these ulcers. So stage 1, non-blanching redness with damage under the skin. Remember, blanching is when we push on something and it turns white. So they get red, and then if you push on it, it's no longer blanching. There's a lot of blood gathering to this area. Stage 2 is a blister or even an ulcer, right? So a wearing away of tissue that can start to affect the dermis and the epidermis. Stage 3 is they are now moving through the epidermis and dermis. They're actually moving into that adipose layer through the fascia. They're basically down to the muscle at this point. And then stage 4 is invasion through the muscle, and now bone is visible. So let's pull up some horrific photos. Yeah. Boom, boom. Yeah, so the common site, this is the tailbone right here, okay? But these are pressure ulcers. This is obviously an infected pressure ulcer. But let's do this, stages. Right, so from a diagram perspective, stage 1, epidermis, non-blanching redness. Stage 2, it's starting to work its way down. Stage 3, we're into the fat tissue up and until the muscle. And then stage 4, it's worked its way all the way through. Okay, so kind of like this. And you can get these ulcers anywhere that's going to be putting a lot of pressure. Bone, it's usually like elbows, heels, as you can see, but places that are bony prominences pressing through the skin. Okay, questions on these ulcers at all? Okay, yeah, the first one I showed you was the stage 4. That's the yucky ones. And that's also, think about from a shock perspective. If someone has unchecked decubitus ulcers, what kind of shock are they at a high likelihood of being in? What did you say? Not hypovolemic. Septic shock. Yeah, infection. Think about that nasty green in those pictures, right? That's infected tissue. Okay. All right. Questions on skin at all? Yes, go ahead.
Are you going to look at maybe an elderly abuse situation if you come to a home and you see these kinds of...
We'll talk about it. We're going to get to abuse near the end here. Yes, of sorts. Okay, so toxicology in older people. Well, we already kind of talked it through. Their livers don't work as well, their kidneys don't work as well, so they don't process medication as well. So that puts them at a higher susceptibility of toxicity. And the reason being is if your liver and your kidneys don't work very well, those are our filters. So these people might have, say they took a medication, backtracking for a second. Let's say we have a healthy, like 25-year-old, and then we have a older person. They take the same medication. Well, the younger person's body filters much more effectively than the older person's. So they're going to clear that medication out. They took the same med at the same time. That medication may stay in the older patient's system for extended periods because it's not being filtered out as effectively. Well, where this becomes problematic is if we start talking about things like pain control, right? If someone takes, I take hydrocodone because I have chronic pain. Well, if you advance your scope and you want to give pain meds, you got to ask when was the last time. If it's within an hour, you're not giving anything because you can double up that CNS effect, okay? But it can make things difficult. So kidneys undergo changes with age, right? Decreased liver function makes it harder for the liver to detoxify blood. It also makes it harder to eliminate alcohol and medication. So they're going to have them flowing around more, I don't want to say more frequently, that's not the right word, but more consistently. They're going to have a hard time purging and getting rid of those toxins. Okay? So, and typical over-the-counter meds can have negative effects when mixed with each other or herbal substances or alcohol or prescription meds, right? Anytime we start mixing substances in our body, we put ourselves at risk. Okay? And especially with older people, I'm sure some of you have seen it or may know someone like this, but if you look, they've got their whole Sunday to Saturday pill container and it's full of 5 to 6 pills per container. Okay, they're taking lots of meds all the time. It can start to wear down on the body. Now, where this can also be problematic, I'll talk about that after this. So, polypharm refers to the use of multiple prescription meds by one patient, right? So, polypharmaceutical, if we even think about your pharm benchmark with Narcan, right? Polypharm, something to look out for, but multiple meds. So, they can have negative effects that include overdosing and negative medication interactions, okay, depending on what they're taking. There's also what's called medication non-compliance. So reasons people don't take their medications appropriately. And there's several reasons for it. These are just examples. Financial challenges. That's why like when they made insulin really expensive, that was problematic because people were gonna literally die if they couldn't afford it. So they were then taking their insulin in kind of sketchier methods or not taking it as frequently as they need to try and prolong it and preserve it so they don't have to pay so much money all the time. Inability to open containers. Right, those child locks get everybody from time to time. Impaired cognitive, vision, or hearing ability. So I've even had, this was not an older person in this call I'm going to tell you about, but it was a developmentally delayed kid who was in a facility and he got a hold of somebody else's medications and he just popped them, assuming they were his and his own. So there could be interaction going on. Now, one thing that I don't think this book does justice to, or the slides don't do justice to, is another consideration that a lot of older people see lots of doctors. Well, these doctors don't talk to each other, okay? Or at least not frequently. As an example, my grandfather, before he passed away, he had a neurologic condition that I'm not gonna get into, but basically he saw 3 different doctors. One was his personal care, one was a referral, one was a referral from the referral. Each one of these doctors put him on steroids. Now steroids you use for like a 7-day period and then you're done. But each one was an increased dose. And each doctor said, he was like, should I stop taking my other medication or my other one? And they're like, no, you'll be fine with this dose. Well, it turns out later he had to go to the hospital because he was starting to go into kidney failure because he was taking so many steroids that the doctors weren't communicating with each other. So he was overdosing for extended periods of time. Okay, so that's something you got to consider as well, right? And that might even be it might feel silly to ask, but how many doctors do you see? How many doctors that you see have prescribed you something? Are you taking all of them the way they're telling you to? It's worth asking, okay? Questions on that at all? Okay. Depression, also not a normal part of aging. It is a medical disease. Now remember, with depression, there are justifiable reasons to be depressed. It's not depression as a disease process until it's a chronic thing. Multiple months at a time or multiple months out of every year, okay? Treatable with medication and therapy. If it goes unrecognized or untreated, higher suicide rates noted in the geriatric population, especially comparatively from male to female. Male geriatrics tend to choose much more effective methods, for lack of a better term, okay? But we'll come to that. So, risk factors include a history of depression, chronic disease, and loss. I've seen this one a few times where, it's a suicide attempt because they have cancer. They've had cancer. It's not going away. It's probably going to be what kills them. And they get sick of the treatments. Or I've seen it too, like one guy in particular comes to mind. He was having a heart episode and he's like, I don't want to go to the hospital. I'd rather just die here because my wife just died two months ago and I want to go see her. And it's like, yeah, sad stuff. But it's one of those things that's very real, right? And it's justifiable for them to feel that way. Remember, they always have the right to refuse, and it's not always the best answer, and we don't want this by any means, right? And suicide is, opens the door for things like holds, psychiatric holds, and things of that nature. But it's a commonplace thing you see in older situations. So other contributing conditions, substance abuse, isolation. We're not designed to be alone. We just aren't as human beings. We're not designed to be alone. We're very much like a tribal thing, for lack of a better term. But prescription med use can start building up, and then chronic medical conditions. Each of these can add to that depression, and the more depressed someone becomes, the higher likelihood suicide is. Questions on this at all? Okay. So suicide, like I said, older men have the highest suicide rate of any age group in the United States. Usually older people choose much more lethal means than younger victims, as well as male to female. Females typically in the data show that they go for things like drug overdoses or carbon monoxide poisoning. Men have a much higher likelihood of just shooting themselves. It's very, very common. And then on top of it, if they do make a suicide attempt because their body is already not in a weakened state, but it doesn't work the same, doesn't recover to the same degree, even if they do survive the attempt, depending on what they did, they may not survive following, right? They don't have the capacity to heal from however they made the attempt. So some common predisposing events and conditions. So death of a loved one, physical illness, depression, hopelessness, alcohol abuse, alcohol dependence, and then loss of meaningful life roles. They say one of the biggest killers of geriatrics is retirement, actually. Not having a role in your life that you're supposed to fill. Bad for your mind. Now, when assessing a patient who displays signs of depression, it's appropriate to ask if they're considering suicide. Okay, now a couple of things. If the answer is yes, the follow-up question we ask, do you have a plan? If they have a plan, the likelihood of following through, much, much higher. We also got to make sure we ask any homicidal ideations with that. Suicidal ideations, homicidal. If they don't care about their life, they're less likely to care about yours, okay? And then make sure you write this down, you include it in your report, document everything. If you don't document or chart it, it didn't happen. Questions? Yes?
When do we call the cops again?
Basically, the second they say, I want to kill myself, that's opening the door. Kind of a positive change is that a lot of, like, before I left, for example, MPD, Meridian PD, they were trying to make it so it's not so much of a you're on a hold, but can we be convincing to get the patient to seek their own help? So they're trying to avoid pushing holds because holds don't always have compliance of recovery. But if someone decides, you know, I should go to a hospital, that it's like they made the choice, they tend to follow the plan a lot better. Yeah, good question. Any other questions on suicide? Old people suicide. Okay. GEMS diamond. Okay, so created to help you remember what's different about older patients. So not intended to be a format for the approach or replace ABCs, just something to consider. So it's an acronym for the issues to consider. And here we go. So in the geriatric patient, older patients may present atypically. Okay, so remember, not everything is going to be so cookie cutter. So be familiar with the changes of aging, kind of like we talked about. What's the environment like? Okay, so the environment can help give clues to the patient's condition and what the cause of the emergency is. Okay, so that's kind of like scene awareness, just typically. The M is our assessment. Okay, medical assessment. So older patients tend to have a variety of medical problems and numerous meds. Get a thorough history. Another thing, remember, history solves your mystery more often than not. If it's happened before, it can happen again. I'm having chest pain. Have you ever had a heart attack? Yeah, I've had 3 of them. Well, it's not crazy to say this is number 4. Okay? And then social assessment. Older people may have less of a social network. They may need assistance with activities of daily living, and then consider obtaining information pamphlets about some of the agencies for older people. So like, resource pamphlets. That's something that's very commonly on most emergency apparatus to some degree. Just give them to the people who can help out, or we can potentially help out. Now, this one, older people may have less of a social network. Some people in the geriatric have a bigger social network than they used to. I've seen several, typically older gals, who they are the social butterfly of their assisted living, which is fantastic and is great for their mental health until one of them gets sick. I had one gal, there's a nursing home, I'm not going to say specific names of. We show up for a sick patient. The first thing I asked was, what's your guys' COVID rate? What's your pneumonia rate look like? They're like, or flu rate. And they're like, we're at 0 right now. It's like, oh, that's good news. I walk in, sure enough, this gal looks and sounds like she has the flu. I was like, okay, well, you sound sick, sounds like you have the flu. Have you been around other people? She's like, well, I had my veterans breakfast this morning. I was at the bingo hall last night. I was at lunch with these people yesterday. I was like, well, when did you start feeling sick? 3 days ago. Here we go. And then sure enough, the next week was just running flu patients out of that facility. Okay, so it can make things more difficult as well. There's some questions that, a lot of them come with experience, but it definitely is something you can start internalizing. What's the potential that this is not just one person, now we are spreading this illness around? Questions on GEMS diamond at all? Okay. So some special considerations. If they have communication issues, you may have to make it work, right? If they have a hard time talking, make it work. Hearing and vision deficits, if you can find their hearing aids, put them in. If you can find their glasses, put them on. Help yourself, okay? You might even have to get creative. I've had to bust out whiteboards, chalkboards to have conversations with people because they're so hearing impaired and they don't, even if their hearing aids don't work, they don't help, okay? You're gonna have to get creative. Even your phone is a good one, right? You can type into your phone. I used to also use my tablet, the narrative portion of my tablet, and I would write questions back and forth with people. Okay, so if you gotta think it through, think it through. They might have alterations in consciousness at baseline, right? Oh, coming back, I got a thought on that one. But if we're talking about dementia, Alzheimer's, that's gonna make, at baseline, their mental status is difficult. Their medical histories could be complex. Same thing, if they have a complex medical history, they have a lot of medications on board, probably. Okay, so that can make things difficult. So let's think of a question real quick. For alterations in consciousness, we show up to a facility, your patient's 90 years old, has had dementia for 10 years. How do you think we're gonna get their A and O? Are they gonna be oriented if we ask them questions? No. Is that abnormal for them? No. So what should we ask, you think? Or who could we talk to? Caregiver or family member, yeah. Talk to staff. Is this their baseline? Are they far from cognitive baseline, right? Because we're not gonna get A and O. These are also the type of situations you're gonna call a lot of family members on the phone. You're gonna talk to a lot of people. I used to just call them on my personal phone, okay? You're gonna talk to lots and lots of people. A lot of times they have like a medical power of attorney who's gonna make their medical decisions for them, and you wanna keep them in the loop. Yeah?
How do you find out who their power of attorney is if they can't tell you?
It's on their paperwork,
yeah.
Typically. I mean, if we show up to someone's house and it's just them in there, you're probably not gonna know. Just do your best treating.
Or their paperwork once they have it posted, right? Like that's
not
necessarily easily accessible if they're outside of a nursing or
right.
facility, right?
Yeah, if they're not in a care facility, you're just gonna do your best. More than likely, you're just gonna take them to the hospital for whatever complaint, and then the hospital will do their due diligence and dig. Yeah, but also look for I used to rifle through purses, try and find an ID so I can get names, and then, once we have a name in our system and we transfer them to the hospital, more often than not, older folks have been to the hospital at least once, they'll have the follow-up.
And it's totally fine to document this stuff in your personal...
I'm not documenting anything, but I made phone calls. Oh yeah, I mean, I would be really hesitant on keeping any of it. It's just like a back and forth communication, that's fine, but make sure you delete everything, right? Because HIPAA stuff. But yeah, that's why chalkboards, whiteboards go a long way. Every ambulance had this is a metal clipboard, but you could write on it with a expo marker and it would erase. So yeah, good questions though. But yeah, usually if they're in a facility, they'll have that number, and more often than not, they've already been called. The power of attorney has been called prior to us even arriving.
In facilities.
Yeah, in facilities. Okay, scene size up stuff. Not a lot really changes outside of paying attention to our locations, right? Like we were just talking about. Facility to home, depending on what their situation is very different, okay? Access may be hampered. There's one call, it's actually one that the gal had a chalkboard in her house, but me and my partner ended up scaring this poor woman half to death because she was had a super difficult time hearing. And so we're knocking on her door. We can see her through her front window in the kitchen. She had accidentally set off her medical alarm, but we have to confirm it. And so we're knocking. She's not turning around for nothing. We're yelling. And so he goes around, and then in front of her sink where she was washing dishes, there's a window, and I just see his head pop up, and then I see her throw a plate. And then she saw us at the door, and then that was the end of it, and she was fine. But you gotta get their attention, okay? And then sometimes, this is also, unfortunately, these are the demographics, we end up booting a lot of doors down. Like if you think about single older person lives alone at home, they fall down, they can't get up. They can't answer the door. We end up breaking a lot of doors or climbing in through a lot of windows. And then depending on how frequently you see these people, sometimes they have their spare key is under the rock or their garage code is X, right? So sometimes that'll be in your call notes. And then sometimes you might have to call dispatch, hey, do we have a garage code? Do we have a key location? Things of that nature. Take note of negative or unsafe conditions. Just be aware of yourself, right? MOI, NOI, what does it look like? Nothing really changes from our assessment perspective. It's still ABC management, okay? And obviously it's gonna look different depending on the condition we're worried about. History, this one, especially with the older people, you're gonna have to do a little more digging because they're gonna have more, Just a longer history, more to write down, but more to dig through, which honestly gives us better answers a lot of the time too. Okay. Sample history. Secondary, if there's no need to get hands-on, don't get hands-on, but same time, we can use palpation as a rule out. Remember, protect their modesty as best as you can. A lot of times they don't care. I've literally heard like putting an EKG on, you're gonna have to expose their breast. I'm gonna lift your right or your left breast up, I'm gonna put these stickers underneath. Is it okay? And most of the time they're like, oh yeah, people do this all the time. And they're fine with it, okay? But same thing, still try and protect their modesty as best you can. Vitals, nothing really crazy there. Oh, I will say though, trying to get a blood pressure on an old person, especially older women, they do not like them. Do not like them. So if you're gonna take a manual, this is the time where maybe you listen on the way up to when we hear the last beat on the way up, and then we listen back down, okay? And the reason I say that is because if you put an automated cuff on them, they're gonna start screaming at, you're ripping my arm off, heard it 100 times, but then they're gonna start doing this. Well, the more they do this action, the tighter that cuff is gonna get. So it's a potentiating problem, okay? So if you're gonna take a manual, control it as best you can, but then also understand you may have to coach them through an automated blood pressure. Hey, just relax as best you can. It'll be over quickly. Just bear with me, okay? Reassess every 5-15 as needed. Document everything. Okay, that was the changes. Let's get into trauma, or medical side. Let's get into trauma a little more. So, conditions that create risk, complicate assessment. They have slower homeostatic compensatory mechanisms, meaning they don't go into compensated shock as quickly. I actually am going to digress. Let's take another 10-minute break for a second. Sound good? Okay, let's get back to it. So geriatric trauma, old people getting hurt. So like I was saying, so slower homeostatic compensatory mechanisms, meaning they don't get that compensated shock as effectively. Okay, and remember what I was saying about how kids compensate versus adults? Kids compensate really well till they don't, and adults is more of a gradual thing. That gradual gets worse and worse because they can't get that pulse rate high to compensate for that low blood pressure. They also have limited physiologic reserves. Our reserves is our adipose tissue, our fat. Well, like we talked about, they have a thinner layer of adipose, so they don't have as much of that backup fuel. Okay, now these are normal parts of aging, fortunately. And then on top of that, there's gonna be the pre-existing medical issues as well. So some physical findings in an older adult, they may be more subtle, they can be easily missed, right? Kind of like I was talking about with that dementia patient. When I touched her, she said, ow. It can be tough. Another thing is that it doesn't take a lot for that to be, or excuse me, it doesn't take a lot for them to have the same amount of trauma. A fall is a life threat to old people, to older geriatric folks, okay? I've seen one gal in particular, she fell from standing and she's maybe 5'3", and she ended up breaking her humerus and dislocating the shoulder on the same side. And it was a pretty standard type fall that honestly I've fallen the same way several times before. Okay, so as you get older, you don't handle that trauma as well. On top of that, you don't recover from trauma as well. So it's often less successful. And then on top of that, when you do recover, it takes way, way longer. That's why they tell you if you're going to get a surgery to get it while you're younger, because you'll recover and the likelihood of it being less problematic later in life is higher. And then many injuries, under-triaged and undertreated, because one, patients don't acknowledge that like they have the pain receptors, they're limited, so they may not know that they're in as much pain as they are, or two, they're going to be dramatic with it. And I don't mean dramatic in a bad way, but like every time you touch them, they say, ow. It's hard to appropriately triage and treat someone if you don't know what's really hurt, okay? Older pedestrians, they typically lose in the vehicle versus pedestrian argument, okay? They don't typically do well when being struck by a vehicle, with commonly suffering injuries to the legs and arms, okay? Legs because the car hits them, arms because they're outreaching. There it is. And then the secondary impact can also cause serious injuries. So they get hit by a car and then thrown into whatever. Even the ground, being hit by a car and thrown to the floor is going to be a potential serious injury, right? If they hit their head, which for anybody that's a potential, but especially with the older folks, okay? Now, older people are more likely also to experience burns because of altered mental status, inattention, or compromised neurologic status. That's another one I used to see my grandpa do all the time. He was teaching me how to do welding. I make silver jewelry, and he He used to burn himself all the time on metal because he would grab it and he would just not tell that it was as hot as it was. And he'd be like, oh, would you look at that, I burned myself. Pretty common thing. That was a neurologic compromise there, okay? But risk of mortality also goes up. So they have pre-existing medical conditions that might make things worse, okay? Their immune system is weaker, okay? And then fluid replacement is compromised because of complicated because of renal compromise. So pre-existing medical conditions, it's going to be harder for them to recover from the burn for whatever reason. The immune system's weakened, so infection risk is way higher. Remember, when we burn ourselves, we're getting rid of that top layer of skin, that top defensive layer, okay? And then fluid resistance. If people are in renal failure, kidney failure, they are on a very strict fluid intake diet, okay? Well, if they're burnt and they're losing a lot of plasma, they're becoming hypovolemic. But their kidney failure is going to make it so we can't really recoup that fluid, at least not very quickly. Okay, so it adds some difficulty to the whole thing. So higher mortality from penetrating trauma in older adults, especially gunshot wounds. You might see gunshot wound as GSW, just fair warning. And then falls are the leading cause of fatal and non-fatal injuries in older adults, with nearly half of all fatal falls in geriatrics resulting in a TBI, right? They hit their head, they have bleeding in their head, or their brain gets rattled around. High risk, okay? Questions so far? Okay. So remember, anatomic changes in trauma. So they have the changes in pulmonary, cardiovascular, neurologic, musculoskeletal systems. It's going to increase their susceptibility to trauma. Okay? Susceptibility meaning that they are at a higher likelihood of sustaining greater injury because of trauma. And then their overall physical condition may lessen the body's ability to compensate for simple injuries. Kind of like we talked about, they're homeostatic. That search for balance in our body is compromised. They don't balance themselves back out as well. Okay, so trauma tends to become more serious because they're not able to compensate to buy their body time. Okay. Osteoporosis, it's come up several times. Hip and pelvic fractures. Remember, with hip fractures, when we say hip, it's usually the femoral head that's breaking or the femur itself. Shortened leg, external or lateral rotation of the foot. Okay, that's going to be our identifier. Dislocated hips, shortened leg, medial rotation of the foot. Now, some contributing factors, stresses of ordinary activity. Right? If they don't move much and they're starting to move again and they're potentially osteoporotic, they're going to have a harder time. If they do fall, there's going to be damage. Standing falls, right? If they're falling from standing just flat out, they're not going to be able to catch themselves as well. When you're walking and you fall, you're already in motion, so you tend to catch yourselves a little better. From a standing fall, not so much. They have vitamin D deficiencies and calcium deficiencies. Both of them are necessary for our bone strength. Okay, they might have metabolic bone diseases, so the breakdown of the bones, just from whatever reason, osteoporosis being an example. And then they can also have tumors on their bones. Cancer, as we get older, it's one of those things that starts showing up more frequently because of, there's a lot of reasons we can point towards. But it does tend to show up later in life, especially due to exposures to certain things at younger ages. And then with age, the spine also stiffens. Okay, they become more rigid as a result of shrinking disc spaces. So remember, between each vertebrae, we have that disc. Well, that disc gets a little bit smaller, and then also our vertebrae, as our bones get weaker, it's just a bad combination. Okay, so compression fractures, top down, something hitting them on the top of the head and smashing their spine together, it's pretty frequent. You can either have the fracture of the vertebrae or at minimum that slipped disc, that ruptured disc in between those vertebral bodies. Because brain tissue shrinks with age, older patients more likely to sustain closed head injuries like I talked about. Their brain atrophies, gets small, puts tension on the vasculature, so if they hit their head and that brain starts to move, things start to tear. Okay? So acute subdural hematomas, among the deadliest of all head injuries. Okay, and then serious head injuries are often missed because the mechanism may seem minor. Remember, I don't want to say that old people are more fragile, but to a degree they kind of are, right? It doesn't take as much of a mechanism to cause harm. Same thing with kiddos, right? It doesn't take as much mechanism. Questions so far? Okay. And last one, other factors that predispose older patients to serious head injury, long-term abuse of alcohol. So remember, alcohol atrophies the brain, age atrophies the brain. You do both, a little bit of both. Okay, recurrent falls or repeated head injury, the more frequently you fall, the higher likelihood you're gonna hit your head. That's math, okay? And then if they take an anticoagulant medication, if they take a blood thinner and they hit their head and they start to bleed in their head, they're gonna bleed a lot in their head. And that's because their clotting factors are not as existent, okay? Questions, comments, concerns? Cool. So environmental, remember internal regulation, temperature regulation slowed. We don't have the adipose as we get older, so we don't insulate as well. So half of all deaths from hypothermia occur in older people, including the most indoor hypothermia deaths. One of the coldest people I ever saw, this was like April, it was spring, was a gentleman who fell in his bathroom. I think I might have told this story. Fell in his bathroom after a shower on a Friday. We didn't find him till Sunday, and he was on the floor naked and not wet anymore because it dried out. But he never warmed up. And think of the temperature of that linoleum floor. It's not warm. Okay, so indoor hypothermia happens pretty frequently. And then death rates for hyperthermia are more than doubled. Remember, they don't sense temperature change as well, so they stay out in the sun for extended periods of time. And then people older than 85 or 85 and older are at risk. This is one that we see pretty frequently in like the older ladies who are tending to their gardens. They like to spend time in their garden. It's hot outside. They don't really notice that it's getting hot. It's been 3 hours. They drink no water. Start to see the heat emergency. Or even inversely, I've seen it in men, older men before, when they're mowing their yard and just tending to it, mowing the grass, trimming the edges. They want to stay mobile. They want to stay active, and that's great. They just got to be a little bit more aware of their temperature changes. Questions on that at all? Okay, so some special considerations. Remember, trauma is never isolated to a single issue when you're assessing and caring for a geriatric. Be thorough. More often than not with trauma in older people, it's one that's not the only injured extremity or injured portion of them, because bone rigidity can go down. Okay, but two, we got to start thinking, is there a medical implication to this? Is something in your medical history cause you to fall down, which has caused the trauma, right? Now we have two things we're trying to contend with. Like a syncopal episode in an older person who falls down and then they meet the floor with their forehead, right? That's a double problem. What causes syncope? And then now we got a potential head injury to manage as well, okay? Remember, in real life, unlike your guys' assessments on Thursday, where it's gonna be, that's a medical, that's a trauma, real life can get really complicated and complex. There can be 2, 3, 4 things going on at the same time. End of the day, which one's gonna kill them first? Let's manage that, ABC. Questions? Okay, so scene size up, nothing that crazy, right? I would say use the environment to kind of give you clues. So if you see a scenario where like you walk up and you see a person on the ground and a ladder lying next to them and they're outside, good indicator of what might have happened, right? Use the context clues. So if we're gonna do trauma, remember it's CAB or XABC, exsanguination being the X. History, I would say this is where it becomes pretty relevant, right? If they have a history of osteoporosis, it would make sense that they're gonna have a history, or the bone breaking is what I'm trying to go to. The bone breaking would make more sense, right? So history can still guide us a little bit, and remember, it can be complex, so trauma and medical work together pretty frequently. Is there something in your medical history that caused this? Did you crash the car, then have a seizure, or did your seizure cause a car crash, right? Got to make those choices. Secondary, hands-on, remember systematic head to toe, focused assessment as needed, okay? Reassess every 5 to 15 as needed as well. This is just, if for hip injuries in general, I think I might have mentioned this, if you can bend their knee and pad under their leg, they're gonna be far more comfortable. And the more comfortable they are, the less they scream the entire transport, and the more you can think, because it's hard to think when someone's screaming in pain the whole time. I think rightfully so. And then document everything. Okay, so I've talked about these facilities kind of intermittently throughout the lecture today. Got to stop and talk about them a little more specifically. So many calls occur at nursing homes or skilled care facilities, and these calls can be challenging for a few different reasons. One, patient may be altered at baseline. That's going to make things tougher. Two, staff may be spread pretty thin. It's not uncommon. I've literally shown up Like I found the room I need a handoff report, what's going on, and then I have to go hunt down a nurse to talk to me. It's not an uncommon thing. Okay, I'm not gonna say all of them are like that because there's some truthfully very good care facilities out there. I would just say in my experience, the majority have been less than that, okay? And then asking what's wrong with the patient or what's new or different today, right? Because a lot of these people as well become a bit of frequent flyers for us. We see them quite a bit. You start becoming familiar with people. Well, what's different from last time this happened? Okay, and then having conversations with staff. I would really recommend trying not to be, because they're gonna irk you in ways you've never been irked. They're gonna push every last nerve you have, okay? Don't start problems, because remember, if you start a problem with them, next time your agency goes back, maybe not even you, they're gonna act the same way they're acting now, maybe even worse, because they're gonna be defensive, okay? I'm not saying don't ask the right questions, but don't make a problem if there's no need for a problem. Infection control is a big thing we got to concern ourselves about in these facilities, right? Like I was kind of talking about that gal who got everybody sick. But staph infections, MRSA is a pretty common one. Skin infections. A lot of older people tend to get cellulitis as well. Inflammation of that external layer of skin, just red and irritated. That becomes an infection source. Staph lives on our skin. There's how it enters, okay? Many infections are caused by vancomycin-resistant enterococci. So vancomycin is an antibiotic, so antibiotic-resistant bacteria. And then RSV, respiratory syncytial virus, can cause an infection of the upper and lower tracts. Remember, that's the one that was common with kids during cold and flu, because one person gets sick, one kid gets sick, they go to school, everyone gets sick. Same kind of idea in these nursing homes. If one person gets sick, everybody gets sick. To that same degree during COVID, they were actually using, like if someone tested positive in a nursing home in Meridian, they had a couple of different locations where that's just where they took their COVID positive patients. If you had COVID as an older person, you're gonna go to where everyone has COVID to try and stop your facility from getting sick. Unfortunately, those facilities had a lot of death coming out of them because people are not healthy typically, and then COVID on top of it didn't help. But at the end of the day, it could have been so much worse had they not moved these people, because then we would have had multiple infections throughout every facility. Okay. Clostridium difficile is a bacterium responsible for the most common cause of hospital-acquired infectious diarrhea. This is C. diff. If you've never been around C. diff, count your lucky stars, you haven't been around C. diff. But also understand, once you've been around C. diff, you'll never forget what C. diff smells like, what that situation is like, because they will have diarrhea literally until they get so dehydrated they die. But typical alcohol-based hand sanitizers also do not kill C. diff. They don't get rid of it. And then fun fact about C. diff, the only way to get rid of it is to find somebody who has a healthy bowel biome, right? Good gut health, and then they got to get their stool in their body. So it was always described to me as a poop transplant, which in my mind I thought like whole tube in the middle. I was like, that's awful. But then I found out how it really happens. They send someone home who has a healthy gut biome. They defecate into a jar. They will then freeze dry that defecation and then make them into capsules. And I don't know which one's worse, if I'm being truthfully honest with you. But
Pop 'em?
yeah, they pop them. Pop a poop pill.
Do they all? So is that coating on the outside
It's the gelatin.
protecting you from like that getting absorbed early? Right, because like there's a lot of other bad stuff that can make you really sick. Like
That's why they have to test the
urine,
bowel.
sterile and- Okay.
They test the bowel that they're going to pull from. Yeah, and but they use a thicker gelatin capsule, so it takes longer.
Yeah.
Yeah, it doesn't break down in the back of their throat. Yeah, nightmares. Yeah, pretty terrible stuff.
What's it called when they get the blockage?
Oh, ileus, and they start
Yeah.
puking. Yeah, the nightmare of nightmares. Yeah. SARS-CoV-2, that was COVID, right? So affects older, more vulnerable people, and then spreads from person to person through airborne droplets created by speaking, coughing, sneezing. COVID was, if you were around someone in COVID, like especially the older groups, when they would huddle up, problems started to arise, and you would start to see pretty high numbers of it. At this point, I don't know if COVID is exactly the fear that we thought it was going to be. Just seems kind of cold and flu season-y. But what I would still double check is when you go into these facilities, ask what their numbers look like. Do you have any COVID patients? Because if they have one, the likelihood of more people having it goes up. Okay? Questions on these at all? Okay. Dying patients. So you are going to interact with this quite a bit with the older folks. You're going to develop a weird relationship with death because you see it so frequently. More people are now electing to die at home than in a hospital, which frankly, in my mind, more power to them. I'd rather die in my house than in a hospital as well. Now, more of these patients are receiving what's called palliative care. This is hospice. This is end-of-life care, okay? So be understanding, sensitive, compassionate about this, and then determine if the family wants for, the patient to go to the hospital or stay in the home. Now, I want to extend on this. Not just the family. I might have talked about this before, but anybody on hospice, you need to call that hospice line, okay? Hospice can take a long time to get on, like upwards of 6 months to a year to join hospice. I heard that. Sorry. But at the same time, if we take someone to a hospital for reasons related to why they're on hospice, like, oh, I have lung cancer, I'm on end-of-life care, I'm having difficulty breathing, I want to go to the hospital. There are some hospice agencies that will drop people from hospice, okay? So then they're no longer going to get their end-of-life care. In my experience, out of a lot of hospice lines I've called, only one of them ever was like, oh, if you transport them, they're not going to lose hospice. That's the only one I'd ever seen, okay? Call the hospice line, make sure that they know, and then make sure the patient's in the loop as well. If the patient is, has like a power of attorney, make sure you're talking to power of attorney, okay? But you need to make sure everyone's in the loop, because last thing we want to do is take someone's end-of-life care away, and then they spend the last few months, weeks, days, whatever it looks like of their life in pain and dying in a miserable way, okay? Yeah.
So they say that if the patient like goes to the hospital, is that with us, or is that just like going to the hospital in general?
With us, but in general. Now, caveated, like say, you know, I have lung cancer, I'm on hospice because I have lung cancer, but I broke my leg, that's not going to get them kicked off their hospice. If it's pertaining to the reason they're on hospice is when they'll drop them. Because, I mean, they're on end-of-life care for that very reason, so why are we looking for a cure of sorts? Questions with dying patients? I would say also with dying patients, remember that your perspective shifts. If we have someone who dies in home and we do, you know, cardiac arrest, run the code, remember, once we have called time of death, our viewpoint shifts to spouse if there is one. Okay, because then also remember, you know, older people, grandma and grandpa, they've been married for 55 years. You know, one of them just passed away. They've been together longer than they were ever apart. So keep that in mind. It's going to get really uncomfortable. It's going to be sad. Manage yourself, keep yourself professional, and be a grown-up and cry in your room about it later, okay? So moving on to advanced directives. These are DNRs. So remember, specific legal papers direct relatives and caregivers about what kind of treatment they want, especially if the patient can't speak for themselves. Okay, now it's going to say, do not resuscitate, full code, and it'll give you layouts. And remember, we have to see the physical copy. For those of you who are not going to be in Idaho, I don't know what your guys' physical form looks like. That's going to be some research on your end. Okay, but we have to have the physical copy to honor it. It has to be valid, it has to be signed, totally filled out. Okay, just also remember, because they have a DNR does not mean it's do not treat. Okay, so may take form of do not resuscitate order, gives you permission to do not attempt resuscitation for cardiac arrest, and then once again, does not mean do not treat. Just because they have a DNR, that's applicable for when they cannot make a decision. We don't know what they want because they're unconscious and unresponsive. We look at this paper that says don't do anything, or it says do everything. We're going to follow what it says, okay? And then also when if they have a DNR and they're still viable, we're just ABC management, okay? So another type of order, that's the post form, that's the one that we use, that's the physical one we have to see, okay? And then if there's any questions regarding orders or when there are no written orders, initiate resuscitation. So this is one of those where I told you this is where this field is a shade of gray. Right? And different people, different providers have different perspectives. If we show up, older person on the ground, spouse says, oh, they have a DNR, and we say, where is it? They're like, I don't know. You have two choices at this point. The most legally defensible is to start CPR, and then when they provide that sheet, you can cease resuscitation efforts. I've also heard that gray area of, okay, I'll give you 5 minutes. If you cannot find it in 5 minutes, we are starting CPR. Once again, legally defensible is going to be to start. That's what I did. It's the easiest way to protect yourself. on the flip side, understand that by starting CPR and defending yourself legally, cardiac arrest is a violent thing, okay? So you might have some pretty pissed off family members at you. You're doing your job, you're doing the right thing legally, okay? You can manage the angry family as needed, okay? Yeah.
For the advanced directives,
Mhm.
you said that ABCs should like still be intact.
Mhm.
Just keeping the body like viable at that point?
Essentially.
Okay. What do we do with the body at that point? Does somebody come and
So if they're, wait, I don't know if I understand your question. So if when it says ABC should still be provided, that means like we're providing treatment for someone who has a DNR, but they're alive still.
Oh, great. Okay,
Yeah.
got it.
Does that clarify a little better? Okay.
Say that again?
So when it says ABC should still be provided, that's for a patient who has a DNR, but they're still alive. That just means we're not going to just ignore them and says, well, don't resuscitate, so I'm not going to treat you. That's not what it means, essentially. Treat until, yeah, point of that they can. Yeah, Hunter.
If you start CPR on someone who says they have like a DNR, but they can't find it or something,
Mm-hmm.
and then all of a sudden they're like, oh, here's the DNR, what do you just stop?
Yeah, you'll just stop resuscitation, which at some points it'll get difficult. My wife ran the code. I think I told you guys that guy's chest was splitting open. And like the wife's like, oh, he has a DNR, couldn't find it. And then the second, my wife's like, same opinion as I have, like, let's start cardiac arrest, start CPR, do the whole thing. And then the second she's like, we got it, he had pulses again. So, but end of the day, she was legally correct because she did what she had to do. They did, I don't want to say too good of a job, but they did too good of a job and got pulses back. Oh, I didn't know. Okay, moving on. Okay, so elder abuse and neglect. So we see this one from time to time. This is not an uncommon thing. I know when people think abuse, they usually think sexual abuse, child abuse. Elderly abuse is very frequent, very common, and it's kind of swept under the rug, unfortunately, in our country. So let's talk about it. So any action on the part of an older person's family member, caregiver, or other person that takes advantage of the older person's, either the person themselves, their property, or their emotional state. So physical, financial, or emotional abuse, okay? Now this includes acts of commission and acts of omission. Can someone tell me what an act of omission is?
You're intentionally not telling something?
You're not telling something or you're not doing something. It's like have you ever heard of a lie of omission? A lie of omission is I'm just not telling you the full story. I'm leaving portions out. So like, for example, an act of omission. Patient has a trach tube. That trach needs to be suctioned. Well, I forgot to suction it.
Includes acts of omission
And commission. So they're doing something on purpose, like they're physically doing the action to cause harm, or they're just not doing something they know needs to be done, and that's going to lead the patient into a bad way. Yeah. So largely hidden from society. So definitions of abuse and neglect among the geriatric population will vary. Kind of starts entering that legal definition kind of phase. Okay, and then victims are often hesitant to report their problem. And there's lots of reasons for that. There's one guy that a lot of us have suspected abuse, and I believe I mentioned it to doctors, it's been reported, but this guy, his caretaker was a drug addict, meth if we want to get really particular, but he was a drug addict and he would just not take care of this guy. The patient was an older guy in a wheelchair, had a trach tube, would not do a very good job taking care of him, okay? He would, and to the same point when we talked to the patient about it, he was really hesitant of wanting to report it because he didn't have much family around who would take care of him. This guy was the only one who offered to help him. So he's scared if he reports him for not taking care of him that he's not going to have anyone to take care of him. And so is kind of the opinion, well, some care is better than no care, which is not the right circumstance, obviously. That's not a good circumstance generally, but it does happen. That's a fear that a lot of these people will have, is that if I report the person who's abusing me and they're my caregiver or my caretaker, well, if they disappear, who's going to take care of me? Because not everybody has that availability of family or friends. Okay, so the abused person may feel traumatized by the situation or be afraid that the abuser will punish him or her for reporting the abuse. Okay, and then elderly abuse occurs more often in women older than 75. This is Yep. And then abusers of older people sometimes sometimes were products of child abuse themselves. They were abused as children by older people, so as they get older, they're thinking, I'm going to abuse the people who abused me. It's kind of a potentiating problem, right? Growth on growth on growth of negative attitude. So take note of the environment and conditions that the patient lives in, and of soft tissue injuries that cannot be explained by the person's lifestyle and physical conditions. So remember, bruises in multiple stages of healing. If this person is wheelchair bound, it doesn't make sense that they have a bunch of bruises, I don't know, I'm trying to make up a spot that wouldn't be, on their back, right? If they have a bunch of bruises on their back, it doesn't really add up with their lifestyle, right? Kind of putting it together. So suspect abuse when answers are concealed or avoided, and then suspect abuse when you're given unbelievable answers. Have a quick trigger of suspicion for abuse, right? Have those red flags ready mentally. Especially if there's situations too where we're talking to the patient, the caregiver keeps butting in, oh no, I'll talk to him, I'll talk for the patient. Try and get the words from the patient's mouth, okay? That should be already a red flag, and then if the stories don't line up, that's a red flag. Now, information that may be important in assessing abuse includes the caregiver's apathy about the condition. Do they seem like they care at all that this happened? Because if they don't, that's a red flag, right? If they're overly defensive when you're talking to them, what's going on? And then you're not making accusations, but they're like, well, I'm doing the best I can, and they're just getting upset about it. That should be kind of a, raising the hairs on the back of the neck a little bit. If they don't allow the patient to answer, if the patient has repeated visits to the emergency department or clinic for the same complaints, or even if they have differing complaints all the time, that's going to be something we got to pay attention to, okay? If the patient is accident prone, I put that in quotes, right? If there's unbelievable or vague explanations of injuries, that should be kind of problematic in your mind, okay? If they're saying, if the caregiver says, oh, they have psychosomatic complaints, oh, it's just in their head, it's just in their head. Probably not, right? Or at least we got to do our due diligence to make sure it's not. If there's chronic pain without medical explanation, if the patient has self-destructive behavior, eating and sleeping disorders, depression or lack of energy, or if you see a substance or sexual abuse history, and that can be either patient or caregiver. Now, more than likely asking a caregiver this, they're probably not going to disclose that information, but you never know, okay? A big long list of potentials. I had a buddy who he was a banker for a long time, and he was telling me of all the different financial abuse situations that he would run into, of oh, that's my aunt, she's got dementia, so, every other week it's my birthday and she forgets, so I go and collect my birthday check from her, and things of that nature, right? So there's a lot of different reasons or ways that people will be kind of tricky with stealing from the elderly. Theft of valuables is another big one, right? If they're in their house all the time and they got a lot of little valuable things lying around, a lot of times they don't notice things going missing, so it becomes problematic. So signs of physical abuse, right? So inflicted bruises are usually found on the buttocks, lower back, genitals, inner thighs, face, and ears. Typically it's in places that they can't see, right? So if people can't see, they try to hide them, but face and ears should be an indicator of, obviously, contact. If there's pressure bruises caused by a human hand, double check the marks, right? If it's shaped like a hand, that's a good indicator of what caused the bruise. Or even pinch marks, okay? Or grab marks. And then human bites. First of all, human bites are gross. Real high risk of infection. Human mouths are gross, okay? But human bites typically inflicted on the upper extremities and can cause lacerations. If there's an open wound, based on what we know about the human mouth, infection's not that far off. Okay, so maybe sepsis. But typical burns, cigarettes, matches, hot metal, forced immersion into hot liquids. Remember that glove pattern of burn? That's not a normal thing, okay? Chemical burns, and then electrical power source burns, electrical burns. I'm not gonna say those are all impossible to happen organically and accidentally, but if we're already suspecting abuse and we see these things, those should be our red flags, okay? Remember, we talk to PD, we talk to doctors. That's who we report these things to, PD being law enforcement. Signs of neglect is another one. Is this person actually being cared for? Are they clean? What's their dental hygiene look like? Hygiene in general, but dental hygiene as well. If we walk into their house, what's their house feel like? Is it hot? Is it cold? Right? Now, if it's too hot, remember, some old people like it really hot in their house. But it's one of those things, we still got to pay attention to. Let the scenario, the scene guide you. Is there reasonable amenities in the home? Do they have enough food? Okay, do they have blankets? Do they have what they need to keep themselves comfortable and alive? Okay. And then lastly, regard injuries to the genitals or rectum with no reported trauma as evidence of sexual abuse in any patient, generally. Okay, any genitalia injury that doesn't add up, we're going to think about it as abuse until further proven wrong. And then geriatric patients with altered mental status may never be able to report sexual abuse. Did I tell you guys my story about the gal who, at the nursing home that we were worried about potential abuse? Did I tell that story yet? Okay, I'll tell it after this. And I'll talk about it in a moment. And then many women do not report cases of sexual abuse because of shame, pressure to forget, especially in like older women. They tend to be, I'm at whatever age and this is not supposed to be happening to me. They don't want to report these things. They're uncomfortable. They're ashamed of it. Now, the story I'm about to tell is not to try and get you to not believe potential victims, but it is a story to tell you to do your due diligence and double check things. Read into the situation. If you hear a red flag, look into it. So me and a partner, newer at this time, we were dispatched to a memory care facility for I think it was like a syncope or a pass out, something like that. When we get there, this patient was very conscious, sitting in a chair. It was my call, so I needed to do an EKG. My partner was an EMT at the time. And so I was like, yeah, let's get an EKG. And so I'm looking at everything, I'm getting the information, the paper, and then I hear them kind of talking, but it was like, she'll tell me what it is in a little bit. And then she asked my partner turns like, hey, can you guys step out of the room real quick? It's like, that's a little bit weird, but sure. So we step out, leaving the door cracked. So I'm kind of listening what's going on. And I hear, yeah, it looks like it might be infected. It looks like a wound. I was like, okay. And so we get her loaded up on the gurney. We get back in there. And as we're walking out, I pull my partner aside. I was like, what was that? What's going on? She's like, well, she's saying that she was sexually assaulted by her brother-in-law or her brother last week, and that she has a wound near her genitalia. So my partner took it upon herself to take a look at it, and it sounded like it was an infected wound. So at that point, it's like, okay, well, we got to dig into this story a little bit more. So as we're leaving, I find the head nurse. I'm like, I want to talk to you about this. So I tell her the same thing, and this nurse got really flustered and really angry really quickly. She's like, this is the third time she's said this, and she has not had visitors of any of her family in months to years. It's like, okay, so that story doesn't really check out with what we're being told by our patient. She has dementia. That also, who's to say she's not reliving a past thing, right? So then when we get to the hospital, I relay the same exact story that I just told you guys. This is what patient said, this is what staff said. I'm gonna let you guys do due diligence. I ended up coming back later and they said it was a rash. More than likely it was gonna be some urine irritation to the skin. So, point of that story, you're gonna hear things from time to time that obviously you're gonna need to look into. I'm not saying don't believe your victims, but make sure you do some digging, okay? Because based on the stories I heard, I don't know if I necessarily believe her. And I don't love saying that, but it's hard to say with the circumstances I had at hand, okay? So be critical thinkers, use your best judgment, and be thorough on your assessments, okay? Questions, comments, concerns about any of that? Okay, that is lecture.